under hematology and bone marrow transplant, National Guard, Riyadh, will share this second session. So it's my pleasure to introduce the first speaker, so Dr. Claire Rudy, the consultant hematologist at UCLH and associate professor in hematology at UCLN, with particular interest in adoptive cell therapy. Also, she is also responsible for the advanced therapy in clinical services at UCLH, and she will give us a talk about management of CAR T cell toxicity. Dr. Claire?
That's great. Thank you so much for the kind invitation to come and join you. And I'm
sorry I can't be there in person. And I'm going to talk today about management of immunotoxicity in patients receiving CAR T cell therapy. And this is a really important aspect of management, as we all know. These are my disclosures. Now, essentially, we want to start the talk briefly by talking about cytokine release syndrome. And I think most people in the room will be familiar with this syndrome, also with the presentation and grading. But as a sort of a quick recap, it's essentially defined by a fever of over 38 degrees in conjunction with hemodynamic instability and hypoxemia. And the severity is graded by a very helpful AST/CT consensus guideline, and the outline of the parameters are listed in this table. It's pretty common. We see it in anywhere between 30 and 100% of our patients, although more severe phenotypes are less commonly observed. And of course, the incidence depends a little bit on some of the factors such as CAR T cell product use, disease characteristics, and so on. And it's very important for us to be aware that the differential diagnosis here is always neutropenic sepsis, and our default should be to give IV antibiotics in this context. And so in terms of the management of CRS, again, sort of mainstays of therapy include antipyretics and fluids, and tocilizumab, as we know, interfering with the IL-6 signaling pathway has been sort of pivotal in terms of controlling this syndrome. And of course, we have to consider corticosteroids, particularly in the context of tocilizumab refractory cases. And we define that when a patient hasn't responded to 2 sequential doses. We feel that instituting dexamethasone is appropriate at that point. And of course, with plans for a rapid taper, given the burden of infectious complications that we see with the use of corticosteroids in these patients. Now, in terms of when should one use tocilizumab, we tend to use it earlier in older and comorbid patients. And again, we're always mindful of the fact that it does increase the risk of infection. So occult sepsis should be considered, and there are very rare cases of GI perforation. And of course, if we have a CRS syndrome that doesn't respond to our conventional tools in the arsenal, then we have to consider alternatives. And we've mentioned sepsis, but also we need to think about macrophage activation syndrome, or IEC-HLH. And so if we look a little bit into sort of HLH, or immune effector cell-associated HLH, well, what this really defines pathologically is a sort of a hyperinflammation. It's an uncontrolled macrophage activation. And there's lots of different underlying causes for this, but CAR T has been recognized to be a big driver of this syndrome. And the kind of symptoms and signs that we're looking for include persistent fever despite CRS management, a high ferritin of above 10,000 nanograms per mil, prolonged cytopenias, hypertriglyceridemia, and of course coagulopathy, and so on. Now, it tends to be associated with severe CRS in CD19 CARs, but of course we've also seen it with other CARs, including CD22 CARs and BCMA CARs. So we should keep an open mind for it, irrespective of the product that we are using. And in terms of the clinical management, this is a sort of a really nice algorithm just to outline how we define it and maybe what we should do to manage it. And of course, frequent intervention, frequent blood tests, anakinra blocking the IL-1 signaling pathway with recombinant humanized drug has been pivotal and instrumental in managing this syndrome. And of course, we often use that in conjunction with corticosteroids. When the combination of these therapies doesn't control the syndrome, we have to be a little bit more mindful that this is a sort of a very high-risk situation. And in some circumstances, investigators and clinicians have used chemotherapy to try to intervene in this clinical scenario, but there's very little published data to guide us as to what is the appropriate next step in those refractory cases. Now, in terms of ICANS, again, it's something a lot of us in the room will be familiar with. We've treated it ourselves. It affects a large proportion of our patients, somewhere between 20 to 60% of our CD19 CAR T patients, and it onsets usually sequentially after the CRS, between 3 and 5 days post CAR T. And it's severe in around about 30% of patients. And again, we use this hugely helpful ASTCT scoring system that was defined by Lee et al. In 2019. Clinically, there's a really prominent language dysfunction and speech abnormalities, and that's why we tend to incorporate this into our testing strategy for these patients. And there will be a small proportion of patients who will have a delayed ICANS at more than 3 weeks. And again, that feeds into our guidance for the family members and the patient themselves in terms of when they go home, what the signs and symptoms are that they should be looking out for, and when to report back if this should occur to them. The kind of BCMA CARs, it's very interesting when we start to look at different targets. We start to see different syndromes emerging. And with the Cartitude study has reported some quite atypical neurologic symptoms, so movement and neurocognitive disorders, nerve palsies, and so on, that don't seem to be temporally associated with CRS. It seems to be a later onset, median around about the month 1 time point, and it takes a bit longer to resolve. So as we sort of push this technology, this CAR T technology further, we begin to see maybe some unexpected toxicities driven, pardon me, by the CARs, and we have to be very open-minded and consider all of these things as potentially CAR-related. Now, in terms of risk factors for high-grade ICANS, this is our difficult-to-manage syndrome. We know that CD28 zeta CAR T-cell products can be more strongly associated with this syndrome, high-grade syndrome, higher doses of CAR, higher disease burden, pre-existing neurologic compromise, etc. And actually a high fever of 38.9 degrees with hemodynamic instability within 36 hours of your CAR T infusion is very sensitive at predicting for a severe ICANS syndrome. So again, watching those patients closely, perhaps intervening earlier, etc., because we recognize that it is a recognized complication. So management, it's supported for grade 1 ICANS, but corticosteroids with a rapid taper should be instituted for grade 2 ICANS or more. And there's no clear rule for tocilizumab and ICANS. And in fact, it may even make it worse by pushing up the IL-6, which can then cross the blood-brain barrier and into the brain. Now, practical priorities for clinicians. This is a tricky bit. So for progressive CRS ICANS, despite optimal use of first-line therapies, what do we do? And these are sort of some pertinent questions that were outlined by Mike Jane and team in a really nice How I Treat article that was published earlier this year in Blood. So let's look at them in turn. So can we identify patients at high risk of CRS and ICANS? Well, the truth is there are some factors associated with these syndromes. We've touched on some already. We've talked about the type of CAR T-cell construct, CD28 zeta CARs, for instance, but the disease type and biology plays a role. Highly proliferative and aggressive diseases, DLBCLs, BALLs, and similarly, marginal zone lymphoma and transformed marginal zone lymphoma seem to be higher risk for these more high-grade and refractory syndromes. Now, interestingly, from a biological perspective, if you look in the tumor microenvironment and you see more in the way of Tregs, well, actually, that's been shown to be associated with a reduced risk of ICANS in large B-cell lymphoma. So the biology of the disease will also play into the individual's risk. Now, in terms of disease burden, this is something we recognize. The higher the burden, the higher the cytokines, the higher the CAR T expansion often, and that tends to be more often correlated with severe CRS and also, unfortunately, a higher risk of CAR failure. So we sort of feel that debulking patients with bridging therapy prior to CAR should be strongly considered for all candidates, and because it may have a sort of a knock-on beneficial impact on these syndromes. So if we look about preemptive strategies, so, now that we feel we can identify patients who are at high risk, is there anything we can do to prevent high-grade syndromes happening? And again, going back to a really nice table, which I urge everyone to look at, Mike Jane and team, Blooded earlier this year. Well, they've looked at sort of strategies to try and prevent, so fractionated CAR T-cell dosing. So this has been done in several centres, including our own in our BALL studies, but it's also been practiced at UPenn and also in Spain. So there are certain groups that are looking for high-risk disorders such as BALL, fractionating the dosing to help protect the patients. But prophylaxis, you can see people are trying lots of different approaches: tocilizumab, prophylactic dexamethasone, anakinra. And so I guess we probably want to look a little bit in a little bit of detail at these later on. What about early intervention? So almost like preemptive treatment. So during low-grade CRS, should we be giving these patients tocilizumab, corticosteroids? Should we be giving them other entities? So, for instance, there's quite nice exploratory work looking at the use of ibrutinib and itacitinib, which has been used by Matt Frigo and his team over in Boston. And they're running a prospective study looking at the impact of blocking JAK on the incidence of high-grade immunotoxicity. So it's going to be a very interesting time for CAR-T immunotoxicity research to see the outcomes of these interesting studies. Now, in terms of prophylactic steroids, I think we're all familiar with this piece of work where really the investigators in ZUMA-1 identified the high incidence of grade 3 and 4 ICANS events and really wanted to sort of intervene, see whether intervention could reduce the burden of that toxicity. So this manifested as cohort 6. And on cohort 6 of ZUMA-1, patients were able to get prophylactic steroids and earlier intervention with steroid and tocilizumab for low-grade immunotoxicity. So how this manifested, the patients got 10 milligrams of once daily dexamethasone on day 0 to day 2. So you're getting that initial quite high CAR T cell expansion in conjunction with this sort of early intervention at grade 1 toxicity with tocilizumab and further steroids. And so how did that play out? Well, actually the CRS incidence was really quite impressive. So whilst less than or equal to grade 2 events did happen and affected 80% of patients, there were no grade 3 events in this reported cohort. The neurotoxicity, it was still a problem. 58% of patients were affected, but high-grade events were definitely reduced compared to cohorts 1 and 2 at 13%. And importantly, this intervention with early TOSI, early DEX, and the prophylactic approach, it didn't seem to impact upon your overall response rates and CR rates, because you can see the Kaplan-Meier here. It looks like those responses are very respectable. So I think, this is obviously a feasible and a safe thing to do and potentially impacts upon the sort of how easy it might be to give axi-cel to, particularly to older patients and high burden disease patients. The big criticism of this study is that in terms of disease burden matching, that cohort 6 may have had a lower disease burden than 1 and 2. And as a consequence, the benefit of this intervention, it may not necessarily be solely the intervention. It may be that these were better risk patients, for want of a better way to describe it. So let's think a little bit about BALL now. Let's think about preemptive tocilizumab with tis-cel. And this was a nice evaluation led by Kaduke and team again over at CHOP, looking at risk-adapted preemptive tocilizumab in preventing severe CRS. So you've got your children with BALL. They're due to be treated with CTL019. They were categorized at the outset with high or low tumor burden based on the bone marrow blast percentage. And the high tumor burden patients received a single dose of tocilizumab. That was after development of a high or prolonged fever. The low tumor burden group just received standard CRS management. And the primary endpoint was the frequency of grade 4 CRS. Now, interestingly, in the high tumor burden cohort, the incidence of grade 4 CRS, and this is using the UPenn scale, was 27%. And that compares pretty favorably to what was reported in the original studies, which was 50%. And it didn't seem to compromise the overall response. The best overall response was 87% in the high tumor burden group. And in fact, the initial CTL019 expansion was higher in the high tumor burden group. The persistence wasn't different. So it doesn't seem to be negatively impacting upon the kind of markers we use for efficacy of the treatment. So in a sense, this sort of risk-adapted TOSI administration, actually it resulted in a reduction in the grade 4 CRS events, and it didn't seem to affect the anti-tumor efficacy or safety of CTL019. So maybe this is the sort of thing that we should be looking at implementing more broadly, or at least testing more broadly in their patient cohorts also. So imagine the scenario: we've been through tocilizumab, we've been through steroids, our patients are still really ill. What can we do for persistent progressive CRS and ICANS that doesn't respond? So lots of different groups looking at lots of different approaches, often sort of single arm intervention studies, which again makes it harder for us to really fully interpret the results. But this is quite a nice paper that's been published by Verley and team. looking at anakinra for steroid refractory ICANS, and it's a single center experience, and they treated 14 patients with 3 daily doses for refractory ICANS and CRS after Tisacel or Axicel. And what was nice to see here was that there was a rapid reduction in CRS and cytokines and the biomarkers for ICANS and CRS without necessarily an impact on the incidence of infection, for instance, which would have been a concern because it's obviously a side effect we recognize. But what didn't work, well, it didn't have a clear impact on neurotoxicity, and it didn't really result in a rapid tapering of corticosteroids. So I think from this, we can conclude that the role of anakinra is still unclear. It may be a possible adjunct to tocilizumab and steroid refractory ICANS, but actually it may have more of a role in prophylaxis, and I think that's going to be the next thing that really needs to be tested. And those studies are obviously ongoing, those prophylactic anakinra studies. Now, what about the dosing of anakinra? Is this important? So, nice paper again by Gazot and team, and it's really mainly led by the Fred Hutch with some involvement from Valdebrun. And the primary objective of this study was to look at the safety of anakinra in relapsed and refractory CRS and ICANS. And they wanted also to explore the impact on the time from anakinra to resolution of those syndromes and also the TRM. And it was a multi-center retrospective analysis. They looked at 43 patients who received CD19 or BCMA CAR products treated with anakinra. And the indications for the anakinra treatment in this group of patients, if you had a grade 2 ICANS, which was worsening or wasn't improving with corticosteroids, or if you had a grade 2 CRS, again with worsening symptoms despite TOSI, most of the patients had the grade 2 ICANS, as you can see, with 40 out of the 43 patients being in this particular cohort. And what does high-dose anakinra mean? Well, in this particular study, that was defined as more than 200 milligrams per day IV, and 28 of the patients received that dose. Now, if we want to look at the individual treatment courses categorized by anakinra dose, you can see this schema here is trying to show us that effectively the groups were pretty well matched. So there wasn't really a difference between the high dose and the low dose anakinra groups in terms of peak CRS or peak ICANS or duration of steroid or even cumulative dose of steroid. The significant difference really came when you looked at the anakinra dose, which obviously stands to reason. And in terms of the results, well, what was the difference in the dosing? Did the dosing make a difference to these patients? Well, they concluded that anakinra treatment was feasible and it was safe. It was only discontinued due to side effects in 3 patients. That's 7% of the total cohort. The overall response rate to CAR T therapy was very respectable at 77%. But when they looked at the cumulative treatment-related mortality at day 28, for the whole cohort, it was 7%. But when you look at the high-dose anakinra cohort, it was 0%. So for whatever reason, this cohort, in that first 28 days, they didn't succumb to their immunotoxicity or other problem. Whereas in the low-dose anakinra cohort, the mortality was really, the treatment-related mortality was high. And when they looked at this in more detail, they thought that the TRM advantage was still stood despite age of the patient. You correct it for age, correct it for product, correct it for ferritin, correct it for performance status, and so on. So, the kind of conclusion here was that this is actually like a real anakinra-driven phenomenon. And I think when they looked at the sort of resolution of the CRS and ICANS in relation to when the anakinra was initiated, well, they were able to show that was 7 days in the high-dose anakinra group, but for low-dose anakinra, it wasn't reached, and that was mainly due to the high TRM that was observed. And these graphs just reflect what we've just discussed. The anakinra dose, at the high dosing, you can see that the TRM was 0. Obviously, with the low dosing, that was pretty high. And the time to resolution of CRS and ICANS, you can see on the high dose, usually most patients had responded within that first sort of essentially 28 days. They sort of resolved to normal, whereas it wasn't possible to make that conclusion in the low dose anakinra cohort because of the TRM. So if you had to conclude, well, it seems that anakinra was safe for these refractory cases, and up to quite higher doses than would usually be implemented in clinical practice. And the overall response rate was still 77%, despite the anakinra, suggesting that, the anakinra isn't sort of overtly compromising the CAR T cell efficiency. The higher anakinra dose might be associated with faster resolution of your CRS and ICANS events, and it seemed to be independently associated with a lower TRM. But I think, this is the first foray into this as an exploratory piece, the dosing of anakinra. We do need more information on how potent that is. And prospective comparative studies will be really important to look into this in more detail and to help guide management of these really complex patients. And let's go a little bit more exploratory still. So anakinra, of course, is quite well defined. We've got quite a lot of experience with it now. But what about other drugs that modulate T-cell signaling? For instance, dasatinib, the TKI. And again, I really like Evan Weber's work, and this is a lovely paper published in 2019 in Blood Advances, looking at dasatinib as a modality to reversibly suppress T-cell activation. And so they did some nice preclinical work here. You can see on the left-hand side of the slide, you've got a mouse model. This is a leukemia mouse model, an immunocompromised system with a NAM6 tumor that expresses luciferin. So you can detect the tumor burden by bioluminescence. And you can see on the very left-hand side, you've got the mock cells. This is just normal the T cells, which obviously don't fight the tumor. And as a consequence, these mice have got a lot of disease by day 14. In the middle column there, you can see that when you give a nice CD19 CAR, it eradicates the tumor beautifully and the mice are tumor-free by day 14. But when you give that CAR with dasatinib from the get-go, you can see how the dasatinib completely reverses the beneficial impacts of the CAR. It switches the CAR off. And this is borne out really nicely on the right-hand side of the slide, where you look at this panel of cytokines and the red dots indicate the dasatinib group. And you can see the dasatinib is essentially just switching off cytokine production in these CAR T cells. And on the bottom of the slide, this is the really nice bit, is where you can demonstrate the reversibility of this phenomenon. So if you co-culture your CAR T cells with the target cells, and you have them co-cultured with dasatinib, and then you take the dasatinib away, well, on the right-hand side, you can see what happens. So your CAR, if you take the dasatinib away, and that's the group that's called vehicle in the blue, you can see that actually the tumor just doesn't grow. So, the tumor just is controlled by the CAR. But if you keep that dasatinib going, you can see that the tumor outgrows. I mean, it's just enormously outgrows compared to the control condition. So this is really nice. This is a reversible suppression of your CAR T cell cytotoxicity. And again, we just really look forward to trying these approaches in the clinic. There's very little clinical data now, but it's absolutely ripe for exploration, perhaps as an adjunct to management of severe syndromes, or perhaps as a prophylactic strategy. And the same goes for ruxolitinib. Again, this is a beautiful drug because it has an impact not just on the T cells, but also on the myeloid compartment. And we know that the myeloid compartment plays such a big role in the sort of pathophysiology of your ICANS syndromes and also your HLH syndromes. And this is a preclinical piece, again, looking at whether ruxolitinib has any potential in this space. And on the top left part of this slide, what this is showing us is that ruxolitinib gives a dose-dependent reduction in CAR T cell cytokine secretion, so effectively switching off some of their effector functions. But on the right-hand side at the top of the slide, what it's showing us is that despite the fact that these CARs that are inhibited to some extent by ruxolitinib, they're not making as much cytokines, they're still able to reject tumor. So that's an important part of this particular strategy. And on the bottom of the slide, this is trying to understand the biology of how this is happening, which compartments are really being inhibited by the ruxolitinib. And so they've sort of subdivided these into three cohorts here with the ruxolitinib, where group A has CAR T plus PBMCs, and they don't have any ruxolitinib. You've got group B, where they've got the CAR Ts and they've got the PBMCs exposed to the ruxolitinib, i.e. the ruxolitinib is inhibiting the monocyte compartment in that group. And then in group C, you've got the CAR T plus the PBMCs all exposed to ruxolitinib. And what this is trying to show us is that ruxolitinib impacts your cytokine secretion via both pathways, not just your CAR T, but also your endogenous compartments. So it feels like ruxolitinib, given the fact it can intervene and can switch off your myeloid compartment, that might be the key of managing the steroid and tocilizumab refractory syndrome. So this, again, is a piece that really needs to be explored in the clinic. There's not that much out there. There's a case report that I've showed here where ruxolitinib was used alongside methylprednisolone, and the team here are looking at a dual targeting bispecific CAR T for BALL, high disease burden, obviously high risk for immunotoxicity. But what they're showing is that at 10 milligrams BD, the ruxolitinib alongside the steroids managed to sort of turn this syndrome off. So lots of potential, and we look to Matt Frigo to report out on his JAK inhibitor study, which is used in the prophylactic setting. We look forward to hearing the results from that in the near future. So let's think about this. These patients are on a lot of immunosuppressive treatment. Their CAR T cells are very highly activated. Their endogenous compartment is very highly activated. This is a group of patients who are very high risk for infectious complications. And again, let's refer back to Mike Jane's paper published in Blood, where they give us some really nice guidance on supportive care measures that we should be implementing for our patients with severe and refractory CRS or ICANS. Of course, there's the neurologic side of things and the immune and hematologic considerations. And Marianne Subcleve and Kai Rajeski have got a beautiful piece on hematotoxicity that I'm sure they'll be discussing in this meeting. But infectious disease, prophylactic antimicrobials are absolutely key here, and antivirals also. And really having a good, close relationship with your microbiology team and getting their guidance and input is extremely helpful in managing these patients. And I draw attention to this syndrome of cold sepsis while patients are on steroid and other agents, where you get these sudden sort of hemodynamic changes without the sort of the prelude of fever, and it can take you very much by surprise. So we need to be aware of this as a syndrome that happens in these patients that can be lethal. So just if we had to sort of summarize, where are we at in this complex and fascinating field? Well, of course, we're trying alongside Anna Sarita et al. To keep the guidelines, best practice guidelines coming, so that we can all essentially be practicing the same medicine in this ever-changing field of CAR T. But of course, in terms of steroid refractory cases, the data is limited. But there are some early signs that prophylaxis and early treatment of CRS may help to prevent severe toxicity. It's difficult because the single-arm trials are quite challenging to interpret, and caution is urged. So we probably need bigger scale studies with control arms and so on. And I can't emphasize enough how important supportive care is to the safe management of these patients, and the high tumor burden, raised inflammatory markers, the consequences of cytopenias and infections cannot be understated. And biomarker to predict poor response to standard CRS and ICANS interventions would be really helpful in this setting. And to date, there aren't any really sort of reproducible assays that can guide us here. But I think that's a sort of an area of research that really is would be welcomed. So with that, thank you very much for listening. I hope that's been helpful. And if there's any questions, I'd be absolutely delighted to take them.
Thanks, Dr. Rodi, for the excellent overview about the toxicity. So we have time for one or two questions. So,
Thank you so much for this extensive review. My question, when can you put cetuximab in this management for CRS refractory steroid refractory CRS?
Yeah, it's interesting, isn't it? I mean, there are lots of different agents with, and lots of compelling biology. The trouble we've had with cetuximab is just that there's not very much data. But it has the potential advantage over tocilizumab, doesn't it? In the sense of binding IL-6. So it's not just binding the receptor, which is what tocilizumab is doing. So in a sense, it's taking that pool of IL-6 out of circulation so that it can't go up to the CNS to sort of drive the sort of the myeloid sort of activation and the sort of ICANS syndrome. So I like the idea of siltuximab for that regard, but we haven't really, there's not a lot of data and there's not been a lot of trials. But I think if you can access it, I would certainly access it as well. But it's hard, and we can't access it very easily in the UK because of cost. It's really, really expensive in the UK.
Thank you so much.
Another question. So I have a question, Dr. Rodi. So as that in cohort 6, using prophylaxis steroid will lead to decrease the incidence of CR grade 3 toxicity. But when you save the product, actually in the label they mentioned don't use steroid. So in your practice, do you use prophylaxis steroid as cohort 6 or not?
Do you know what we don't? And it's because, like there are people in our centre who like that study, and they like that publication in BJ Heme, and there are other people who get very cross about it because they don't feel that the groups were well enough matched in order to be able to say that the benefit of the intervention with the sort of prophylactic steroids was the arbiter of the reduced incidence of toxicity. They think it might be a sort of like a reflection of the reduced disease burden of that particular cohort of patients. So, because we are a democratic organisation, everyone's view is taken into account. So we haven't been able to push that particular piece through. And I think it's just as well, because we have some reservations because of the incidence of infection as well. I mean, infection and this cold sepsis phenomenon, it has been a big problem for us. So again, there are some of us who feel that it would be a good thing, and we would be quite happy to implement it, and there are others who feel quite strongly that we shouldn't. So democratically, we've elected not to do it. But I think if there were more studies, and if we could sort of demonstrate that the cohorts were well matched and so on, I think more data would help push us towards action, I think.
Okay, thanks, Dr. Rodi. I hope next time to be with us physically here. And thank you,
Yes.
and have a good day. Okay, see you. Bye.
That's great. Thank you very much then. Enjoy the rest of your session.
Okay.
Bye.
Bye. Thank you. So it's my pleasure now to introduce second speaker. So Dr. Zenida Birish is a hematologist and assistant professor at the School of Medicine, University of Zagreb, Croatia. Also, Dr. Birish's research activities focus on immunobiology of the graft-versus-host disease and role of the gut of microbiota in the pathogenesis of intestinal GVHD. And she'll give us a talk about managing steroid refractory chronic GVHD. Dr. Birish?
Thank you so much for the kind introduction, and I hope you can hear me.
Very honored to be a part of the SS BMT annual meeting, again virtually, but hopefully next time we meet in person. And I'm also delighted to talk about steroid refractory chronic GVHD, because actually this field is becoming interesting nowadays with the new drugs emerging in the field. This is going to be the roadmap of my talk. I will try to start with definitions and endpoint clinical trials, move on to clinical trials and recent approvals of the drugs in the setting, but also not to forget ancillary and supportive care, and end with the new NIH consensus and the perspectives that it gives in the field. So, starting from definitions, I think we are all very well aware that even this is hard in steroid refractory chronic GVHD, and that we haven't had good definitions for a long time. Several years ago, though, NIH, EBMT, and CIBMTR have joined forces and tried to provide us with a consensus on the definitions of steroid refractory GVHD. And this is the paper that was produced in 2018 and defines steroid refractory GVHD, the one which is progression on steroids for 1 to 2 weeks, or stable GVHD for 1 to 2 months. While steroid dependence is typically referred as inability to control GVHD symptoms on tapering in at least 2 individual attempts separated by at least 8 weeks. However, I think it's very also important to acknowledge that many of the patients have to stop first-line treatment because they're steroid intolerant. Of course, we are all very well aware of many of the toxicities of steroids. Among of them, many are unacceptable, and therefore patients will need also the second line. Actually, less than 20% of patients with chronic GVHD achieve durable, partial, or complete responses and survive 1 year after initial therapy without additional systemic one. And therefore, steroid refractory GVHD is really an unmet clinical need. We know that staging, diagnosis, staging, response, that all has not been very well established in the past, but thanks to the NIH initiatives, thanks to the NIH consensus in 2014, we really got this cleared. And also what we have had in the meantime to pave the way for clinical trials is, besides having short-term endpoints as overall response ratio, which we can get from phase 1 to 2 trials, and we are sometimes not able to wait long-term survival and time to off immunosuppression as a result of phase 3 trials. We have more recently, or maybe in the last 10 years, have started to evaluate an intermediate outcome, which is failure-free survival, which along with the taper of steroids is really an adequate outcome measure from phase 2 trials, which really helps us move on with clinical trials and approval of drugs. Failure-free survival has been shown that it can serve as a meaningful endpoint for clinical trials. In this study from 10 years ago, where actually failure-free survival, as we know, is survival without relapse and without the need of the change of therapy or that additional immunosuppression. And in this study, it has been shown that failure-free survival after second-line treatment is 56% at 6 months, 45% at 12, 1 at 24, and only 25% at 48 months. And that withdrawal of immunosuppression happens in only 15% of patients at 48 months, really, again, underlining the need for new drugs in the field and highlighting steroid refractory chronic GVHD as an unmet clinical need. This after the NIH initiative and the FFS really, let's say, advanced clinical trials. And I think how desperate was this field shows the fact that really soon after, actually in 2017, we got the first drug and approved by the FDA, and surprisingly after a phase 1b/2 study. We all know that ibrutinib in this study was evaluated in patients who failed 1 to 3 previous therapies, and this study gave us, but mostly in skin GVHD patient, gave us an overall response of 67%, but had only median follow-up of 14 months. However, this was enough for its approval. Later on, we've seen with a longer follow-up of 26 months that the overall response is sustained, and also that FFS at 18 months is 51%, which compares favorably to historic benchmarks of 35%. Also, 2/3 of patients reached acceptable lower level of steroids, and meaning that both besides short-term outcomes, the mid-term outcomes were also satisfying. However, when it comes to toxicities of ibrutinib, we know that these are significant, although grade 3 to 4 adverse events are mostly fatigue, diarrhea, infections, and pneumonia. I think that we have to acknowledge that discontinuation rate to side effects is 43%, and it might be even more in the real-life setting, because when we conducted in the EBMT a survey on the management of steroid refractory GVHD by the Transplant Complications Working Party, and we have done that in 2021 before of the approval of new drugs. Although mostly European centers, we had a huge population of 105 centers in 33 countries. And here we have found that the practice for the second line is really heterogeneous. with most centers actually using more than 2 agents, so not having a standard second line, although 65% of centers do have a standard operating procedure. Actually, the most used agents in the survey or in the centers, but found in the survey, were ruxolitinib and ECP. With, as you can see, a huge list of different agents used, and ibrutinib falling only on the 6th position in 90%, used in 90% of the centers. Of course, many of the centers include patients in clinical trials, but what is also, I think, important to highlight here, and I will mention it again later, then only a third of centers treat patients through a GVHD team or through a multidisciplinary approach, which I think is crucial in chronic GVHD. However, later on that year, and of course, the use of ruxolitinib was mainly done by the data that we had from retrospective trials. But very soon later, in 2021, after this survey, we got the results of the REACH3 trial, which we all know compared ruxolitinib to best available therapy, a list of 10 common choices, where most common were ECP, MMF, and ibrutinib in patients with moderate severe GVHD. And we know that this study showed that overall response of ruxolitinib was significantly better than best available therapy, which was the primary endpoint, and secondary endpoint were achieved, as well as higher symptom response and better failure-free survival of 18 towards 5.7 months, or 75 towards 45% at 6 months. And also decrease in steroids, so again, a midterm outcome, was slightly higher in the Rux arm, although the paper didn't show the real numbers of that. 69% also had a maintained response at 1 year, and all this led to approval by FDA in September of that year, and a bit later by EMA. But here, most of the patients actually had one previous line of treatment, and it was approved in patients who had inadequate response to steroids or other treatments. So really approved as the real second line. When it comes to toxicities, grade 3 infections, what is of course always important in those patients treated with several lines, were similar in the two groups in comparison to best available therapy. However, 16% of patients on the Ruxo arm discontinued treatment, which seemed higher than the best available therapy. And we know that that's mostly because of the grade 3 toxicities, and which are cytopenias in ruxolitinib, which we of course face every day. When it comes to highlights from the EBMT, I think this year's EBMT was more focused on acute GVHD, but as opposed to the previous one, where we had lots of these data on chronic GVHD. But we did see something interesting that I think is a highlight, and that's orally presented data on crossover to ruxolitinib from the same study, which showed that ruxolitinib has high efficacy and manageable toxicity even after the best available therapy. So let's say after as the third line in patients after week 24, when the primary endpoint was evaluated. So if progression, flare, stable disease or toxicity in 1/3 of patients, that happened actually. And we can see here that patients, and 69 of them changed best available therapy to ruxolitinib, showed actually comparable overall responses to the middle column, and that's the ruxolitinib arm, so 48 to 49%. And also the rate of serious adverse events was similar. Also, interestingly, only 7% discontinued treatment in this arm in comparison to the Rux, which was 16%, as I mentioned earlier. This moves me to the third line and the trials that we have on belumosudil. Belumosudil is, as we know, and that's the trial is called the Rockstar trial because the drug is the ROCK2 inhibitor, which does two things. One is shifting Th17 to Tregs, and the other one, which is really important, is the antifibrotic action and reduces fibrosis actually by downregulating the TGF-beta signaling and profibrotic gene expression, which is really important because we know that once fibrosis happens, chronic GVHD becomes irreversible. Belumosudil was evaluated, we know, in two trials, phase 2A study in 54 patients, and then later on the right, a phase 2 study in 132 patients. Two dosages were tried and worked similarly, so 200 milligrams per day is the dosage that is then recommended. And overall responses were more than 75%, and as shown here on the right, it worked in all subgroups. So in patients who received ibrutinib before, ruxolitinib before, who had more than 4 lines of previous therapy, who were diagnosed with chronic GVHD before a long time, so meaning that it really worked in all these subgroups. When it comes to responses across organs, it also worked across all organs with really impressive data in joints and fascia, which we know is a huge problem. And the median time to response was 5 weeks, with most of the responses happening in the first 6 months. And all this was enough to approve belumosudil by the FDA as in steroid refractory GVHD, actually after failure of at least 2 prior lines of systemic therapy in July of 2021, or as the third line. When later on we saw the accept of these short-term outcomes, the intermediate outcomes, and that was done by a pooled analysis of these 2 trials, we saw that FFS was 75% at 6, 54 at 12, and 38% at 24 months, in comparison to historic rates of FFS of 56, 45, and 31%. Of course, it is considerably better. When it comes to risk factors which are associated with treatment failure with belumosudil, this study also showed that these are the progressive chronic GVHD, steroid-free upfront, and more than 2 prior lines of therapy. Also, 2/3 of patients were able to reduce steroid dose. Side toxicity was acceptable. Serious adverse events happened in around 30% of patients, with most frequently described side effects being fatigue, diarrhea, nausea, and cough. Well, this actually brings us from no drugs in the steroid refractory chronic GVHD to having 3 after the last couple of years. And of course, this always brings us to the new question, which drug then to choose if we have all available, and once we hopefully will have them. Of course, when we face-to-face comparison are not very realistic, but when we compare the results of these studies, we can see that efficacy and toxicity is similar between those 3 drugs, between overall response rates, so short-term outcomes, FFS, mean steroid, this is similar. Also, serious adverse events with a bit more in the ibrutinib trial, but it means that if we have similar drugs, it becomes, of course, harder to choose. But in these terms, we will have to, in the future, try to see which drugs works better in which organ, and of course, choose by the affection of organs in our specific chronic GVHD patient. Of course, that means individualization of treatment. And also, since most of the responses that today we have are partial remissions, we will also have to think of combinations. But when thinking of combinations, we have to have in mind biology of the disease. We have also learned a lot in the biology of chronic GVHD. Luckily, we know that most of the targets so far have been in the phase 2 in blocking the priming of T and B cells. This is how ibrutinib and ROCK2 inhibition works as well. But the focus today is really moving to phase 3 and the drugs that have the antifibrotic effect as well, because we know that phase 3 is driven by macrophages, which then induce fibroblasts, which then depose extracellular matrix, which leads to sclerosis. I have to also, we have drugs now, but I also have to mention, and I would really like to highlight how important is ancillary and supportive care, because I think in steroid refractory and chronic GVHD in general is really, really something irreplaceable and has to be at least as important as drugs. And here I think we should follow several postulates. First of all, we have to have in mind also the natural course of chronic GVHD, and although this is an autoimmune disease, it is not an autoimmune disease for life, because immunological tolerance does emerge. We don't want to miss that moment. And therefore, chronic GVHD should be evaluated regularly every 3 to 6 months, even if we are not changing the drug or nothing is changing with symptoms. But intensity of treatment should be calibrated periodically by lowering immunosuppression to allow chronic GVHD to emerge before increasing the dose. Also, we have to have in mind that most patients die from infections, and this study here on the left shows that patients who have immunosuppression at 1 year after transplant actually die more, which is very important. And therefore, everything listed on the right, antibiotics, antivirals, antifungals, vaccination, is very important. We have to have in mind in these patients, and also we have to have in mind to treat them with at least systemic immunosuppression as possible. This is sometimes possible with adding ancillary treatment with local therapies. How important this is highlighted by the whole in one of the NIH documents. The whole one is dedicated to ancillary and supportive care. Luckily, these local treatments are developed well and work best in oral skin and eye GVHD, which are the most frequent manifestations as well. And considering aggressive local therapy can actually, or increasing local therapies can actually help us decrease the systemic immunosuppression treatment, which is the goal. And also what I've mentioned before, and I think it's really, really important, is that ideally patients should be managed not only by a BMT physician, because it's really hard to treat a multisystemic disorder like chronic GVHD by only one specialist, but ideally chronic GVHD patients should be through a dedicated GVHD multidisciplinary team with different specialists involved, and that this really works has been shown before, but this is an interesting small study which showed that patients involved in this way of management and evaluated before and after 1 year of the management through multidisciplinary approach actually have significant improvements in quality of life, which is of course our ultimate goal. What about the perspectives? Finally, well, after paving the way for new drugs, by the second NIH consensus, the third one held in 2020, is now shifting focus to prevention of steroid refractory GVHD by working on identifying risk factors for highly morbid forms on early diagnosis, maybe with biomarkers, which we know that we don't have so far in this setting. Also preemptive treatment in high-risk patients, and focus maybe moving those agents that work in the second line to first line and moving towards steroid-free approach. Also, better management of highly morbid form is especially crucial. And as I said here, the focus is really moving to antifibrotic drugs. One of the more recent drugs that is becoming interesting is axatilimab, which has been evaluated evaluated in phase 1 to 2 study, which is interesting because it actually interferes with macrophage-driven fibrosis, and this is very, very recent data just published, this drug was evaluated in 40 patients, phase 1 and 2 study, and in patients who were pre-treated, who got ibrutinib, ruxolitinib, belomucil before, who had median prior lines of 4 and median 4 organs involved. And here they reached the primary point with the overall response of 50% at day 1 of cycle 7, but in all overall responses after 6 cycles were even 82%, and importantly a very nice improvement of quality of life of 58% and responses across all organs. When it comes to identifying new highly morbid forms, also we might not be able to use biomarkers still, but maybe some of the new diagnostic tools are becoming interesting. And I like to mention this study always because it's an extremely interesting approach, and that's artificial intelligence involved in chronic GVHD, where this was published in Hematologica, and patients evaluated according to the NIH consensus criteria were actually analyzed by a computational approach, and 7 different phenotypes that we haven't recognized so far have been recognized here, which could be stratified into risk groups, which then stratified survival very well, as you can see here on the left. And this could also be very easily reproduced in the clinical setting by a simple decision tree, which you can see here on the right. Finally, when it comes to highly morbid forms, we are moving, and this is the perspective, I hope, for the future as well. We have some of the new data in belomocidil, INDBOS, where this is a more recent data on 59 patients from the earlier mentioned study, where the overall response rate was 39%, and it worked, of course, better in patients with the lower baseline NIH lung score. Also, and this is really the most recently, the already mentioned axatilimab also has been analyzed, only preliminarily low numbers, 32 patients, but it seemed in these 32 patients, BOS was present in 15 patients with median of 5 previous treatments, and in these 15 patients, actually 8 patients had a partial remission and 5 of them had symptoms improvement, which is, I think, really respectable data, and acceptable toxicity was seen as well. So I think with this I will stop, and thank you for listening, and also I will be very happy to take any questions.
Thanks, Dr. Bersham, for your overview. I think we have questions. Take the mic, please.
Thank you, Dr. Berish. I have a question regarding the patient who have suboptimal chronic GVHD with suboptimal response to ruxolitinib. Now, belomucil, do you add belomucil to the ruxolitinib, or do you stop it and use the belomucil? Do you add it in combination, or you stop?
No, I do not have personal experience with belomucil, I have to say, because it's not available in my country. But usually it should be stopped as soon as possible, because, of course, adding to it is going to increase the toxicity. So, well, I didn't hear very well the question. I'm sorry.
Again, the same point. Can you use combination to optimize the effect?
Yeah, I think that's something that we have to address in the future, because most of these responses are actually partial remissions. So although responses are impressive, I think responses are not good enough. So this is something that definitely needs to be evaluated in the future. So combination treatment is something that I think is crucial for improving those partial remissions that we have.
Thank you for this excellent presentation. What's the impact of controlling the severe chronic GVHD on the chance of the disease to relapse? We know that, you know, those high-risk diseases, they are with chronic GVHD, they may have prevention of relapse. So how do we have any data saying correlating the use these second line or third line agent on the chance of the disease relapse?
Thank you so much. It's a great question, but unfortunately, we don't still have that data. We know that chronic GVHD, we have in our mind that it protects from relapse, but it seems it's not really clear that it really protects from late relapses. It does protect from those early relapses, but there's still a high incidence of late relapses in chronic GVHD patients, and therefore it will really become interesting to see how these drugs also incorporated in the treatment affect the rate of relapse. But of course, so far we don't have any data on that.
So I have a question. So regarding how do you fit ECB with the available of this medical therapy in steroid refractory chronic GVHD?
ECP, the question is ECP, right?
Yeah.
Yeah, that's a great question, because when we talk about combination treatment, thank you so much, because it's really, and the first question was related to that, I think, of combining the new drugs, which do have rate of infections, which we cannot and ECP is an attractive drug, or let's say tool to combine, because it does not add on immunosuppression. There are some small data on ruxolitinib in combination with ECP, both I think from the group of Professor Zeister, and these data are small, but do show some good outcomes. So combination of ruxolitinib and ECP has been published, and I think ECP is a very attractive therapy to combine with these new drugs, because it might improve the partial remission rates without adding on toxicities.
Okay, thank you, Dr. Barish. I hope, thanks for the presentation. Hope to be with us next time physically and to be in the virtual. And thanks again for your presentation.
Me too. Thank you so much.
The last lecture in this session is going to be presented by Dr. Ali Al-Ahmari. It's about T-cell therapy, adult local experience from King Faisal Specialist Hospital. Dr. Ali Al-Ahmari is a consultant in the adult hematology and tumor transplantation at King Faisal Specialist Hospital, Riyadh. He is also one of the CAR-T program leaders in King Faisal Specialist Hospital. And also he contributed in the research in hematology and lymphoma and stem cell transplantation. Welcome, Dr. Ali.
Assalamu alaikum. Thanks, Dr. Zahan, for your nice introductions, and thank you for the SS BMT committee for inviting me for this talk. My talk will be focused mainly on the adult experience of the CAR T-cell therapy at King Faisal Specialist Hospital. There's no conflict of interest for this talk, and there is unpublished data in this presentation. So as you know, the CAR T-cell therapy, it's work like as collecting T cells or normal T cells from a patient as auto, and it gets manufactured and gene editing, and then it get 3 to 4 weeks to proliferate and then get infused to the patient proceeding by lymphodepletion therapy, and it get causing apoptosis for the malignant cell that has the target for the CAR T-cell. So for this slide, just to show how the journey of the CAR T-cell therapy get approval over many decades, and the green box or the green title here is just to show you the Saudi FDA approval for the commercial CAR T-cell product. In 2020, Saudi FDA has approved the T-cell for diffuse large B-cell lymphoma and for acute lymphoblastic leukemia up to age of 25, and in 2022, the approval for Axi-cell for diffuse large B-cell lymphoma has been approved by Saudi FDA. So this slide, just to summarize what has been published, has been approved for the B malignancy as well as myeloma, the construct of the CAR T-cell and the co-stimulating, as well as the approval for these products. This slide as well, just to show us how, specific indications for each product. For example, if you see the T-cell, it has no approval for primary B-cell lymphoma, while in Axi-cell it has some approval. And if you go to the Liso-cell, it has some approval for Burkitt lymphoma grade 3B. So that one fine. And Brexu-cell has an approval mainly for mantle cell lymphoma and adult PLL. That's for the third line and more of relapse. Later on, we have 3 well-known clinical trials that address the using of CAR T-cell therapy as a second-line therapy. So ZOMA 7 and Transform and Flender study showing the positive study for Axi-cell and Liso-cell, while T-cell was not a positive study. So by these 3 clinical trials, the approval for second-line therapy for Axi-cell and Liso-cell has been established. So if you look to the data from CIBMTR up to 2021, you see how the numbers of the CAR T-cell increased, and indications as well, especially for the elderly population who has no or not fit for autologous stem cell transplantation. With regards of our experience in the Kingdom, and especially at the King Faisal Specialist Hospital and Research Center, it's actually started a long time ago because of some logistic issues of data approval of the commercial product, and without hiding the thankful for Dr. Ali Lahmeri from Pediatric. He was leading of the CAR T-cell at the institution with his team. So the CAR T-cell was approved, and we start the infusing the for the T-cell for pediatric and adults. So from the adult section, we try to establish guidelines, and as all of you know, with experience that you pass through, when it's get to a new field, then you have difficulty to find the supportive materials. So we try to get a lot of materials through overseas from colleagues from different institutions. So we established, this is actually draft book or booklet for the guidelines of the CAR T-cell therapy at King Faisal in adult section. So as all of you know, the King Faisal is established for a long time, and it has specific special interest for some of the rare diseases like oncology, transplantation, and genetic disease, as well as heart disease. I'm not going to spend a lot of time on this one, as all of you know. So in hematology at King Faisal, it has high volume of hematology and BT program, averaging patients for around 90 inpatients, and at one time last year, the inpatient reached up to 120 patients. You can see here this figure to see how the progress in the transplantation or cellular therapy, and the green spot here or the figure here is just to show you the addition of the CAR T cell in the cellular therapy. This is part of our BMT and CAR T meeting that's launched every Tuesday. And this is the first CAR T cell therapy or history to CAR T cell started by this first patient. I think he was a patient with pediatric. So he was infused in January. Actually, it was in pediatric in December 2020, and the first adult patient was in January 21. So actually, this is the first patient. He's my patient. He was 56 years old. He has ABC, diffuse large B-cell lymphoma. He was refractory for arch of 6 cycles. Pit interim was NCR. Then he has because he has disease in the inguinal area. He received radiation therapy. Then 2 months later he relapsed. So he was started with ESHAC, but he has progressive disease. Then at that time, CAR T cell was not approved in the kingdom. So we gave him another salvage. So he has some partial remission. Then at that time, before the CAR T cell get approved by Saudi FDA, we start to apheresis him. And actually at that time, because it was the first patient, we were afraid that maybe the manufacturers will be failed or something like that. So we did for him auto collection for stem cell transplantation. In case the manufacturers failed, then we'll go for transplant and partial remission. So he received another, because we saw that there is a partial remission with RI-GIF. So we gave him another as bridging therapy after the collection. And then he received the T-cell as a CAR T-cell therapy. 2 months later, he relapsed after the CAR T-cell therapy. And you can see this is his first presentation before CAR T-cell, at the time of the collection. You can see how bulky disease he has. And then he has some, so he has a good control of the disease at day 30 of the CAR T-cell. He still has some remaining disease here. So I gave him lenalidomide just to, at that time, the ASH has a publication of lenalidomide has some immunomodulatory effect on the CAR T-cell therapy. So he had some partial remission at that time. So spent for him for around 3 months. Then he relapsed. He has prone relapse. He came as ECOG form, pit bound. So he was given one dose of Bola-PR at that time. Bola-PR still was in compassionate program. And then there was a bispecific compassionate program. He was enrolled in that compassionate program, which is glofitamab. So he received glofitamab. Thankfully, he achieved complete remission. So he completed 12 cycles of glofitamab, and he was allografted from haploidentical donor. So this is the first patient. Actually, the CAR T was not the curative intent for him, so he required another modality. So what we are doing in our institutions, so we established the MTD meeting for CAR T cell therapy. So it's launched, and some of our colleagues from different institutions has presented their cases, which is on Sunday at 4 o'clock. So we do assessment of the patient, and then we will usually we do an MTD presentations. It has to have at least 5 consultants to do a vote for eligibility and taking decisions for the CAR T. And then there will be also in that meeting the apheresis lab colleague to be on the same field. Then patient will be booked for apheresis, and the choice of the product will be depends on the label indications as well as the disease entity. Bridging therapy also to be decided in that meeting according to the patient's need and aggressiveness of his disease or her disease. Then once the product arrived, usually we don't start lymphodepletion until we have the product in the institution arrived. So this is the algorithm that's for any patient with diffuse large B-cell lymphoma. I'm not going to spend a lot of time, as each institution, especially with the different consensus on that regards whether to take the primary refractory or those relapse within 12 months. So still it's debatable, especially with the cost effectiveness of the CAR T-cell and the speed. So I think each institution has their own program or guidelines. However, I think we should have a national guidelines to have clear for all patients how we treat them, especially with this high cost impact therapy. So this is also for ALL up to age of 25, and I think Dr. Lahmari from pediatric will talk about the experience from pediatric and indications after that. So this is how the CAR T cell is a bit complex. So it's need a lot of stakeholders from the patient, nurses, coordinators, apheresis, pharmacy, ICU, neurology, cardiology. So all specialties has their input on the CAR T cell. So what we do when we started the CAR T cell therapy, we try to do some of the collaborations, and some of the colleagues from different specialty has an interest. So we had an infectious disease specialist who has an interest for CAR T cell therapy. So we used to see, or she used to see a patient before the CAR T cell therapy by 1 week or so to clear patient and look for the infectious issues in that regard. And then patient get admitted with some advice regarding the prophylaxis. When we started the CAR T cell, we used to have our colleagues from the intensive care unit to round the patient on a daily basis. And the RRT nurses has to see patients Q8 hours just to see the vitals. We did audit almost 6 months after we start the program, and we have a lot of patients, and we found that there is no need to continue seeing a patient in floor unless the patient reached grade 4, grade 2 of CRS. So this is just kind of limitations what I have mentioned. Some of the issues for the fitness of the patient, we need to take care of. Age is not, I think, a major impact, especially if there is indications for or label indications. Now, the age is keep increasing to be enrolled in the CAR T cell therapy, and if you look to the ZOMA-1 study, the higher age was, I think, around 92 years old. So history of malignancy also important. ECOG performance status is an important issue, especially for the outcome and the data supporting that issue. So ECOG more than 2 and higher DH has adverse effect on the outcome of the CAR T cell therapy. Tumor burden as well has correlation with the toxicity, so we have to assess a patient for that and using the best bridging therapy or decrease the burden of disease before that. Prior allo transplant has issues with regarding washout period, active GVHD, immune suppression therapy. So all of these has to be taken in the patient fitness and enrollment in the CAR T cell program. Some of the clearance, if you look to many institutions, there is no clear guidelines for that, but many of the data adapted from the stem cell transplantations, like infections, hepatitis, HIV, COVID-19. So a lot of things has to be, we try to manage it and look for different institutions, how they are doing, especially those who has good experience, and we try to merge it together and have a local or institutions-based clearance package for data. So some of the product has a specific issues to tackle, like hepatitis and HIV. So for T-cell, they have some prohibited things for hepatitis, while in access cell they have different parameters. So I think for each product we have to establish what the need is for manufacturing. And for example, also for T-cell, high burden of blast, then it may affect the manufacturing rate. This is just kinds of the CAR-T workup package we do it. I'm not going to go over them, but most of them is adapted or from the stem cell transplantation. We have two phases of clearance. One pre-apheresis workup phase, and the second one is pre-infusion workup. Most of the work is before the apheresis time. So one important thing, it was clearly illustrated and established with the some product like T-cell. So you have clear guidelines for the washout period. So you have to look for that medications before you are collecting patients for CAR-T-cell. So, for example, the patient behavior like high aggressive lymphoma, then try to avoid bendamustine. It has clearly affecting the manufacture rate and as well as the outcome of the CAR-T-cell therapy, and intuzumab as well. Transplant is there's no, you cannot avoid it if it has been already there. So very important to have a washout period before the CAR-T-cell therapy, and I think part of the, we face some of the manufacturer's failure because of the washout period of some of the medications like bendamustine. So this is the table that we created for all patients. Has to be, if not well captured from the screen, but anyway, so we can see all patient of all of these medications in the literature for washout period should be tackled by the checked by the primary physician as well as the CAR-T coordinator to see if the patient received these medications or not. There's some specific parameters for apheresis for both products, whether for myeloma or lymphoma. So you need to look for that one before you send the patient for collection. Also, there is a washout period before lymphodepletion, like high-dose chemotherapy. If you are going to use high-dose chemotherapy as a bridging chemotherapy, then you need to manage it between the giving that bridging therapy and lymphodepletion. Intrathecal as well, it has a washout period as well as radiotherapy. So this is how looks the CAR-T-cell door at the level 19 at King Faisal. So we established kinds of poster for the ICANS and for CRS for the on-call staff. So they don't need to look for it on Google or something like that. That's, they have to follow these instructions and they have to contact the staff on call or consultant on call on that week or that month for CAR-T-cell therapy. So when we start the program, as all of you know, we try to communicate with all of colleagues from different institutions as well as from the Gulf area. And I have to thank all of colleagues that collaborate with us and presented their cases. And I think that's so kinds of collaborations to establish patients' care in national wise matter. So we received also some patients from the Gulf country that has been infused at the institution. And I'll go over the how many cases that we have infused. So we started by T-cell in 2020. This data only for the adult, and I think Dr. Lahri will present pediatric data. So the T-cell we have infused 25 in non-Hodgkin lymphoma and 14 in ALL, and axis-cell when it's get approved, we have infused so far, not infused, but we have the data for 10 patients who passed 30 days of the infusion. So you can see the median age in the axis-cell is 53 years, and T-cell is 48 years, and in the T-cell for leukemia is 18 years, and as all of you know, it's up to 25 years for the ALL. Male proportions is 30% in axis-cell, 54% in T-cell for lymphoma, and 78% for leukemia. ECOG, less than 80% in axis-cell. There are 2 patients who were before the CAR-T-cell at the time of the collection There were two of the ECOG, but because of the disease progress, they had some difficulty in ECOG performance, but we infused them and they are okay. In T-cell, all of the patients, ECOG performance is less than 2, as well as in leukemia. The lymphoma type, GCB subtypes 30% in axis-cell group and 52 in T-cell group. You can see here, this is the constructions of each product, as all of you know. If you see here the overall response rate and CR rate in axis-cell, actually this is a small number of patients, you can conclude from that, but the overall response rate is 70%, as matching the international data with CR rate of 50%. If you look to non-Hodgkin lymphoma and T-cell, 56 overall response rate and 36 CR rate in the T-cell or for acute lymphoblastic leukemia for the 14 patients. The outcome is CR. Actually, there's no overall response rate. All of them achieved complete remission. Some of them has some minimal residual disease. Actually, didn't have the data, but the CR rate is 92%. PFS, as you see it, we cannot conclude it from axis-cell because it's just short time. In T-cell for non-Hodgkin lymphoma, 1.7 months, and in leukemia, 10 months. With regard to the toxicity, 90% of patients has any grade of CRS in the axis-cell group, and 10% of the patient has grade 3 and above. And all of them were treated and responded to the therapy. We used prophylaxis of dexamethasone for 2 patients, and we used preemptive therapy, which is cohort 4 of the using prophylaxis of dexamethasone for 1 patient who has history of CNS involvement before. In CRS with T-cell and non-Hodgkin lymphoma, 88% of patients has any grade of CRS, and 12% of that population has grade 3 and above. In leukemia group, 57% of patients has CRS and 22 has grade 3 and above. Neurological toxicities or ICANS. In axis-cell, 30% has neurological toxicities, but none of them has grade 3 and above. In T-cell, 24 has neurological toxicity, and 20 of them they have grade 3 and above. So you can see on the right side of the figure the outcome. That's for the whole population with regards of subtypes of ABC and GCB type, and you can see the outcome is correlating or matching the international data. This is actually premature data for the axis-cell, and you can see there are three patients has follicular lymphoma, and the outcome is great as for 1 month, so we cannot conclude that. And also the outcome overall survival as well as PFS is comparable with what has been published, and at least what has been published in day 30 post-CAR T-cell therapy. This is for all population with ALL and diffuse large B-cell lymphoma. The ALL with blue line, the overall survival is 100%, and PFS is around 80, and it's dipped down to 90 and dipped down to 80% after 12 months. And you can see here, this is the lymphoma, the overall survival around 75%, and the PFS is around 35 to 40%. So this is, before I conclude, I have to acknowledge our colleagues in all of the hematology departments, stem cell lab, apheresis, BMT and CAR T coordinating, cellular therapy quality departments, patient of course, and BMT fellow who has collected the data and analyzed it, also the other hematology fellow who has contributed to the collection of data. And with this one, I thank you, and if there's any questions, I'm happy to answer.
Thank you, Dr. Ali. very nice presentation and congratulations for the great achievement over the last 2.5 years and for leading the program in the kingdom and contribution to the treatment of patients at the beginning of CAR-T journey in our country. So we'll open the floor for any questions.
Thank you for excellent presentation. I'm Rabanian from King Talent Specialist Hospital in Dammam. So with your experience in having both products available for diffuse large B-cell lymphoma, the T-cell and the axi-cell, is there an algorithm or a reason to choose one over the other at this point at your center, or?
Okay, this is 1 million question, and it should be difficult to have it without head-to-head clinical trials to see what is the most effective therapy. Actually, there are a lot of factors affecting of taking decisions of which product is over the other product. If you look to the time from the collections, and as you know, once the lymphoma relapsed, then it's progressive disease. So the manufacturing time in, for example, T-cell cells take time because it is cryopreserved, and so you cryopreserve the product, and then you arrange for shipment 1 or 2 weeks later, and it's take maybe 4 weeks to get product back. So this is one factor. The other factor, the construct of each CAR-T cell is different. If you look to indirect data from the second line as a second line therapy with Blender study, which was a negative study compared with the other 2 products, then it just gives you an indirect evidence that this product is not the best options for that populations. However, with those patients who cannot, you need to give them bridging therapy, and you cannot wait, and there is issues of collecting early. Maybe you can collect them, cryopreserve them in institutions, and start them on bridging therapy, whatever bridging therapy you have, and then you can wait for the CAR-T cell therapy later on. So I think the time is a key point for that. And if you look to the colleagues in the state, the median time to have access, especially, and that's, I think, colleagues from KITE has to look for this point. The median time to have the CAR-T cell infused from the apheresis from the vein to vein is 17 days. So 17 days. This is very golden time to have the patient. You don't need to bridging them. Nowadays, I think our experience will even the access up to 4 weeks to have the product. So I think that's key points. To be honest with you, in our institutions, when we saw the result, we tried, majority of lymphoma patients will go for the axi-cell. The reason behind that, because of the manufacturing time. So we collect it today, we send it as fresh, and it is within 3 to 4 weeks we'll have it. So you are saving 2 weeks from delaying of shipment of that system. And because of the indirect outcome, indirect evidence by Blender study, Transform, and Thomas.
Thank you, Muhammad. Congratulations, Dr. Ali, for your work and the whole team. I'm Hamid Isa from Pediatric Hematology National Guard. I'm a pediatrician, but I will ask a question, general practical for you more than, because mashallah, your volume in lymphoma is much higher than the leukemia group and in the pediatric age. And as a transplanter, before going to cellular therapy, we're more used to more toxic, longer admissions, etc. So one of the things that's coming up with at least seeing the patients now getting into it is just a patient who's sitting and doing nothing and want to go home and waiting for the CRS anytime. So the question to you before coming to pediatric is more of the outpatient kind of CAR-T, or in other words, the discharge criteria from the inpatient service. Cutting edge, the CRS peak timing.
Yeah. Okay, so when we start the program, actually, we mandated to have a patient at least 3 weeks to in patients. And then when we saw the, as you mentioned, the peak of the CRS and ICANS, when we saw the peak is around 3 days of the CRS to 5 days, and the ICANS 7 days, and it disappeared. So we start to be kinds of soft. So we start to discharge patients on day 14, especially if they are not cytopenic or not transfusion dependent. So we discharge many patients on that, and actually we don't have issues with that. But actually, after the accessal, because the neurotoxicity is higher, so we also discharge some of patients, but they presented later on day 21, 22 with ICANS. But this was low profile ICANS, was managed in the emergency and discharged. So many of centers now, they are doing the CAR T cell as outpatient. If you have a good setup, you have alarming, you have monitoring at home. Many of them, they are doing that as outpatient actually. And if the patient gets CRS or ICANS, they have reserved bed so they cannot get in. So this is, now we are actually, I discharged one patient at day 7 because never had CRS or ICANS.
Thank you, Dr. Ali. Excellent talk, really, and huge work behind the scene to get to this treatment. Thank you so much. My question, in ALL population, we have seen more relapses after prolonged follow-up. So in your side, I mean, did you apply post CAR T, STC, or transplantation as a consolidation?
Yeah, I think it was. Yeah, it was in the slide. It didn't illustrate more of that because I think each institution has their own field. But anyway, what we are doing, the patient who is naive for transplant, I think it's quite different than pediatric group. I don't know why, but I think the cell dose has an impact on that. As you know, in pediatric, they are using per kg, while the adult more than 50 years, they are using fixed dose, which is 2 to 10 of our millions, to 2 million. So I think that I haven't seen any clear data on that. But what we are doing, what we adapted, the naive ALL patient, we intend to give, if has eligibility or has indications for CAR T cell therapy, we give them CAR T cell therapy. 3 to 6 months from the CAR T cell therapy, we start arranging or taking them for allograft. For those who relapsed after CAR T cell therapy, after stem cell transplantation before, actually we try to just monitor them, try to avoid use of steroid as much as we can during the toxicities profile or very high threshold use of steroid. And actually, some of patients, they relapse after, especially those who has allotransplant before, they relapse after CAR T cell therapy, and we tend to give them another targeted therapy like inotuzumab, and we took them for another transplant. They have 3 patients like that. So in general, naive patients will take them for transplant as a consolidation. Those who has transplant, we'll just keep monitoring them by looking for B-cell aplasia and more MRD assessments.
Thank you so much. Dr. Ahmed?
Thank you, Ali. Very nice. My question would be, we were discussing actually last session, we're here, about local production versus, the strategy. Should we pursue local production? And what's the strategy?
Well, I because I just got my slides only for the commercial product, or approved product. And I agree with you 100%. We have to have our local production, especially for patient who has no access for this program or because of the cost impact. And the data is clearly shown there is no clear difference between the commercial or FDA approval and the local production. Actually, many institutions in state, as all of you know, for those patients, because of the insurance company will not cover these high costs, the look for another, which is in-house production, to have it for these patients. And for the arbitrary decisions by FDA and Novartis by using cutoff of the BLL up to 25 years, that's what put a lot of patients with acute lymphoblastic leukemia in salvage and palliative therapy without clear reason. Because if they are using the same product for diffuse large B-cell lymphoma, same manufacturing, same toxicity profile, but when it's come to the age, 25 is cut off. And actually, I don't know if they are here colleagues from PAD, we have problem with a patient who is 27 years, and we try to convince, actually colleagues from Novartis here, they try their best, but there was big no from the international medical affairs or regulatory to accept that patient. Why? There is no clear scientific answer for that. In our now, we have approved in-house productions for adult ALL. We start the validation phase in 2 patients, and it's successful, alhamdulillah. And I think within 1 or 2 months, we'll start to the first patient for the ALL. And we have another protocol for non-Hodgkin lymphoma as well.
Would that be like phase 1, or how is it?
It is phase 2. Phase 2, because Saudi FDA will be difficult to have phase 1 nowadays.
And just last question, Dr. Ali. I noticed in the ALL group treated with SSL, the neurotoxicity, 28 had all patients had neurotoxicity, and all of them is grade 3 and 4.
Yes, but the neurotoxicity that's happened in the acute lymphoblastic leukemia, all of them are grade 3 and above. And 2 of them admitted to the ICU, but alhamdulillah,
why is that? Because this is not like what's reported.
You're right, but I think the small number it has an impact. Just 14 patients. They think maybe, I don't know, Ali has another experience from the pediatric, but I think the small numbers cannot translate it to what has been published.
Thank you, Dr. Ali. We will conclude this session. And we'll return back at 1 o'clock after the lunch and prayer break. Thank you very much.
So Dr. Ali Abdullah Ahmari, he is graduated from King Saud University Medical College in '95. He did his pediatric residency at King Faisal Hospital from 1996 to 2000. He did his pediatric hematology oncology fellowship at King Faisal from 2001 to 2003, and he did his subspecialty in hematology oncology and stem cell transplant in Toronto Children's Hospital 2004 to 2005. He has over 18 years experience in the transplant. He is specialized in the care of children undergoing transplant, and with a special interest, of course, in the research in HLH. Dr. Ahmari is the Director of Pediatric CAR-T Cell Program and Director of Pediatric Hematology Oncology Fellowship. He is also the Director of the histiocytosis program. He has given many lectures nationally and internationally about this. He's also more than 80 accepted abstract and 48 publications. Welcome, Dr.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullah. Thank you for this nice introduction, Dr. Sundus and Dr. Muhammad. And really, it's an honor to be here today. And I would like to thank this kind invitation from SS BMT. And I was asked to talk about local experience of CAR T cell therapy in the pediatric population. So I would like to thank Dr. Ali and Badr for paving the way for my presentation. Already they have given 2 lectures about CAR T cell therapy and with much focus on the local experience. I'll be taking you through the following outlines, introduction, and then just highlight about our program at King Faisal Specialist Hospital, CAR T journey, then discuss the first case that was done, and then focus on our pediatric experience. As you can see here, this is one of the story of success in the pediatric childhood acute lymphoblastic leukemia, a dramatic improvement in the survival compared with the adult side. So we have really extremely excellent event-free survival, to the degree that most of the clinical trial now is focusing on decreasing and minimizing the toxicity rather than improving the survival. So in spite of that, still we have relapses in about 15 to 20% of our patients. As you can see here, many studies have shown good outcome that can be salvaged with intervention, good chemotherapy or plus or minus bone marrow transplantation. But those subcategories that were early medullary relapse, still we're having a lot of difficulties. As you can see here, BMT for relapse ALL showed acceptable outcome is around more than 50. Those patients can be salvaged with pediatric stem cell transplantation with less transplant-related toxicity and less cumulative incidence of relapse. But on the other side, the outcome of relapse after pediatric stem cell transplantation is not encouraging. As you can see here, the event-free survival here is not really good. Also, the overall survival for those patients, as you can see here. So about the second stem cell transplantation, those patients or this category of patients also is not easy. There is a high incidence of relapse, and there is also increased transplant-related mortality, and also poor leukemia-free survival and overall survival. So there is really an unmet need for another intervention other than stem cell transplantation. Another group that also we had a problem to treat is those non-responder. So those refractory relapses, as you can see here, many approaches have been tried without any encouraging outcome, including stem cell transplantation. So really there is an unmet medical need for the following subgroups in pediatric population: refractory to first line, refractory to first relapse, and second relapse, and those who are not eligible for stem cell transplantation, like Down syndrome, who relapsed after chemotherapy, or those relapse after stem cell transplantation. And those group collectively probably they have poor prognosis with 10 to 30% of survival. So this is the solution after the invention of CAR T cell therapy. Become the solution for those subgroups of patients that we were facing a lot of difficulties. As you all know that the first girl who was infused by CAR T cell in April 2012, Emily Whitehead, and the first worldwide was the first CAR T cell worldwide. And very interesting that CAR T cell persist, so it's giving us the note that CAR T cell is probably a potential for long-term remission. And she is now more than 10 years after CAR T cell infusion. This is the registration trial of Eliana that was conducted multi-international and in different institutions. Based on that, the FDA approval was granted to Novartis for commercialization of this product. As you can see here, the complete or the response rate 81%. And out of those responder, 95% were MRD negative by day 28. The event-free survival at 12 months is 50, and 20 patients relapsed, and more than 2/3 of those relapsers are CD19 negative. And 15% of the responders, about a quarter of them received additional ALL targeted therapy post infusion. So after this licensing this product, many regulatory bodies approved CAR T cell therapy, and most of them agreed about CAR T cell therapy in first relapse only after stem cell transplantation, or of course if it is primary refractory, which is very rare, or CAR T cell therapy in second relapse after stem cell transplantation, or if it is second relapse or more. So what about Saudi FDA? This is the indication, approved indication, which is refractory to first line, refractory first relapse, second or greater relapse, not eligible for stem cell transplantation, or relapse after stem cell transplantation. Currently, we have 2 pediatric institutions infusing CAR T cell. First center, King Faisal Specialist Hospital, started October 2020, and we have done 17 cases so far. And the second is King Abdulaziz Medical City here in Riyadh, started January 2023, and 2 cases were infused so far. So back to our journey at King Faisal Specialist Hospital. Initially it was a CAR T cell project, started with focusing on bringing the commercial CAR T cell therapy to patients, and then also have another arm pursuing the CAR T cell clinical trials, which is already discussed by Dr. Badr in the morning. Actually, we started in May 2019, but the actual work started with Novartis in April 2020. The file was submitted to Saudi FDA. Remember, this is the COVID pandemic. Although, in spite of that, we moved very well, and actually, the approval granted from Saudi FDA in October 2020. So actually a lot of meetings and a lot of education, because this is the first experience to the kingdom in CAR T cell therapy. So a lot of meetings and educational sessions to Saudi FDA, customs, and other regulatory body. And finally, it was approved in October 2020, and we have done first case, Ahmed, as you can see here, in December 2020. Ahmed is the first case in the Middle East and Africa. And as you can see, Emily Whitehead is the first case in the world. So let us just tell you about the story of Ahmed. He is 13 years old boy who was diagnosed in 2012 as standard risk B-cell ALL. First line of chemotherapy. Unfortunately, he relapsed after becoming off therapy. Then he was salvaged with second line chemotherapy. In spite of that, also he had the second medullary relapse. So he was transferred to us from King Fahd Specialist Hospital in Dammam for CAR T cell therapy at that time. The challenging in transplanting this case is actually two issues. Is refractory second relapse, also the cardiac function, as you can see here, due to chemotherapy related cardiotoxicity. So Ahmed was infused with CAR T cell therapy, and in the same day he spiked fever, became hypotensive, admitted to ICU, required norepinephrine, started on tocilizumab and short course of dexamethasone. Fortunately, he was labeled as grade 3, resolved very quickly, and he did not develop any neurotoxicity or tumor lysis syndrome. So in King Faisal, as explained by Dr. Ali in the previous, it starts with CAR T MTD meeting in the pediatrics for all referrals, and then after approval, the patient will be evaluated for the fitness for CAR T cell therapy and many imaging, bone marrow and CSF also, and will be seen by different multi-specialties to decide to make sure that he's fit for CAR T cell therapy and chemotherapy. Also, the washout period must be respected in these cases, as explained earlier. And then the patient will start the journey of the manufacturing. So after apheresis, cryopreservation, and then shipment will take place. And between shipment of the pheresis and getting the product back, it ranges between 5 to 6 weeks. And after receiving the product, the patient will be prepared by lymphodepleting and then followed by infusion. The challenge here is bridging chemotherapy. We have different ways to do it, depend on the disease or burden, whether intensive chemotherapy or light chemotherapy, till we have back the product. Also, the patient has to be post-infusion managed according to the ASTCT guidelines and grading. And this actually grading has been implemented in the system to make it easy for our fellows and assessment nurses. So it was built in the system. As you can see here, the nurses just answer or fill the signs that the patient is having, whether fever, hypotension, or hypoxia, and the system will calculate automatically the grading. Based on that, we'll refer them to the guidelines for management according to the grade that was recorded. So this is our power chart and the documentation of nurses. So it's easy really for everybody. And after discharging the patient, we have to assess the disease. This is very important, as we will be discussed later on, to assess the disease because sometimes we need an intervention preemptively before the florid relapse of the disease. Just one slide to just give you a highlight about the CAR T cell activity, especially Kymriah. Already Kite was presented by Dr. Al-Ahmari in the previous presentation. We have done 99, almost 100 apheresis, 75 shipment were taking place, and 69 products came back to our lab. 4 patients were having manufacturer failure, which is around 4 or 5%. 2 patients were cancelled due to patient's factor. Out of those 69, 55 patients infused. I'm talking now about Kymriah. Infused, pediatric and adult and non-Hodgkin lymphoma also. 10 of those products were disposed because patient factor, either disease progression or patient died. Also, and I'm talking about the pediatric, we have one in the queue waiting for execution, which is using in-house point of care CAR T-cell clinical trial in the pediatric ALL, waiting for the adult study to start it, and probably we are the next. So let us now focus on our experience at pediatric population. We have done 17 cases between December 2020 till April 2023. As you can see here, the median age at infusion 8 years old, predominance of male, and the disease status. Most of our patients, they were having either primary or refractory or relapse after stem cell transplantation. At infusion, still they have a disease burden, CR in 5 patients at infusion. 4 of them, 3 of them isolated CNS relapse without bone marrow involvement, and the other one combined CNS and bone marrow. Transplant, as you can see, almost 50% of our population, they relapse after stem cell transplantation. So we receive them after stem cell transplantation. Age less than 3, we have 12% with MLL gene rearrangement, infantile ALL. Down syndrome, we have 1. Previous prior CNS involvement, as I mentioned, 4. Prior blinatumab or INU is almost in 50% of our population. And number of leukapheresis from the first time in 15 patients, and 2 patients required another collection. The median time to have from collection to infusion is 2.6 months. Sometimes it's not because of the product, because of the patients need to control the disease better. And the median dose is 3.4, which is quite good dose really in most of our patients. So this is the toxicity profile. As you can see here, those patients that required prolonged ICU admission and length of stay, those are the patients, 2 of them, number 15 and number 9, actually they did not respond, and the disease was progressive, and they died in the ICU. The other 2 also, one of them developed severe. This patient developed severe CRS and ICANS, and although was not assessed the day 28 disease, but actually B cell was 0 at that time. So we assumed that the patient in remission but died of the toxicity with multi-organ failure. This patient, also infantile ALL, who shortly relapsed after short remission. His MLL gene rearrangement and develops CD19 negative relapse. So we believe that this toxicity is quite common, and some or several patients need ICU care. So probably this is we have to work on this to control the disease prior infusion better. CRS and benchmark it with other international studies. As you can see, Eliana, the grade 3 and 4 CRS around 48, and any grade 77. In the real world data, CI BMT 16, which is much better. So people they tend to treat those patients better, and also CRS is better than registration trial. At King Faisal is close to Eliana, 41 grade 3 and 4, and any grades around 70. So I think there is much work also to reduce it and decrease ICU stay. ICANS, we have 2 patients who developed ICANS, but it was grade 3, both of them, 12%, which is comparable to other studies. So out of 17, actually we have 4 deaths, as you can see here. First 2 patients, they did not respond to CAR T cell. The disease was progressive and they died. Other patient 3 developed CR, but it was short remission, MLL gene rearrangement, who developed CD19 negative relapse and diseased. Patient 4, he was in remission, but he developed toxicity and multi-organ failure. So the non-response is around 12.5, giving us CR 87. And this is comparable to Eliana, which is, I just mentioned, 81, and real-world data 86. So we are similar to at least real-world data study. What about the relapses? Out of the 4 relapses, including this patient who relapsed MLL gene rearrangement, we have 5 CD19 negative relapse, making 80% of our relapses CD19 negative relapse, which is very difficult really to treat, because you cannot use reinfusion of CAR T cell. So the only thing is putting them in remission and taking them to transplantation. Also, the B-cell aplasia is poor indicator. Those patients, they will continue to have B-cell aplasia, but the relapse is CD19 negative relapse. So 1 year overall survival and event-free survival more or less is comparable to the benchmark studies. As you can see here, CIBMTR study, the overall survival is 77 at 1 year mark, and event-free survival around 52. Eliana around 50, 76 the overall survival, and our study 73 overall survival, a little bit less than the event-free survival due to the relapse that I just mentioned. So when we compare it with the real-world data, CIBMTR, as I mentioned, with more long follow-up, as you can see here, is really comparable to that. Even we have higher survival, but slightly less event-free survival due to the frequent relapses that we have. But you can see here at the bottom here, when we compare our disease, the features in our population and cohort compared with the real-world data, we have more risk groups, like the high-risk cytogenetics in almost 30%, 18% in the CIBMTR. We have high disease burden more than 5%. In almost 2/3, it's only 1/3 of in real-world data. Prior stem cell transplantation, 50% of our population. It is around 28 in the other population. And post-infusion, consolidative stem cell transplantation, we have done it in 2 cases, and they did it in 16%. So when we analyzed, although it's a small number, it's very difficult really to have strong conclusions, but we did it just for sake of the presentation to examine different factors and the impact of those factors on the survival, if we have differential survival or not. Those in red, this really, the event-free survival is significant. And we'll discuss also, compare it with the other studies that analyze those factors. So the cytogenetics, at the relapse, whether high risk or high risk, it matters, especially in the event-free survival. As you can see here, is almost 67 event-free survival compared with 20% in the high-risk group. Also, the prior CNS involvement. So those patients with isolated CNS relapse, they did better, and this is confirmed in other studies. And the disease burden, those patients who were having high disease burden prior to infusion, they do poorly compared with the low burden disease. Another also category, which is of course MRD negative at day 28, as well as other time points, day plus 19 and etc. is very important, and we'll discuss that later on. Duration of B-cell aplasia also, although in our population we did not see any difference, but in other studies it has been shown is very important. And this is, it makes sense, more than 6 months is needed for B-cell aplasia to have good outcome. So let's just compare it with the other study. In the first thing is the disease burden in our population. There is tendency to be significant, and the B value, as you can see here, almost 67 of our patients, they have event-free survival, while 40 in the high disease burden. And this is, it was being studied, as you can see here. Those patients with high disease burden is the 1 year event-free survival is poor, around 34, compared with almost 69-70% in the other disease category. And remember that CD19 negative relapse occurred more frequently on those patients with high disease burden. That's why really to control the disease prior to infusion is crucially important. The other disease or the other factors that we did not show any difference in our study, as you can see here, the p-value is not, it's the whether previous use of immunotherapy like Blina and Eno. But in other study it has been showed that significant difference in the survival. Those who received Blina prior do poorly compared with those the naive for Blina. And this makes sense because Blina sometimes it has an effect on the density of CD19 expression of cells, so probably also more than that it affects the function also of the T cells and its fitness. And the most important really is the MRD monitoring. It's very important really, but most center here we are following disease by flow cytometry, which is I think is not enough. As you can see here in this study, it's really many graphs, but if you can focus on the left side, this is MRD at day 28, MRD 0 compared with MRD more than 0. So you see the differential survival here with survival benefit on those where MRD negative or equal 0 by NGS, not flow cytometry. Also the same at 3 months and 6 months. We also in our population at day plus 9, those who were MRD negative, they did better than those who were MRD positive. As you can see, the event-free survival and overall survival. Loss of B-cell aplasia, this is a predicting factor for relapse. As you can see here is a very nice study showing you that B-cell aplasia at different time points post-infusion. When they're at day 28, at 3 months and 6 months, 9 months and 12 months. Or if there is no recovery of the B cells, that means B-cell aplasia all through. So you see here the outcome is better when you don't have any recovery of B cells, that B-cell aplasia more than 1 year. It's better than when you have B-cell aplasia at 6 months, at 3 months. When you have early loss of B-cell aplasia, you see the event-free survival is poor, as well as also overall survival. So when you combine both B-cell aplasia with MRD monitoring, so this is will give you the best survival actually. So this is the combination. The best survival when you have MRD equals 0 and prolonged B-cell aplasia more than 6 months, compared with those really with early short B-cell aplasia and MRD positivity by NGS. So the role of dose, it has been studied really the effect of dose on the outcome, and this study showed there is a tendency of better survival when you have larger dose of T cell. So it's, if it is as you can see here, when it is less than 2, they claim that it has poor when compared with higher than 2. But in our population, as I mentioned before, most of our population receive high dose more than 3. So we're not able to have a different event-free survival or overall survival in our population. What is the impact of high-risk cytogenetics? In our population, we have really a differential survival in favor of those with low risk in the relapse prior to CAR T-cell infusion. In other studies done by Leahy, they were not able to show any difference in the survival between high risk versus low risk. But other study, they also were able to show differential survival between both categories. Actually, few studies that have been published to address the long-term follow-up of CD19 CAR T-cell therapy. But I have this long-term study, but is not addressing the CD28 costimulatory domain. And you can see here the survival is not as expected. And this is probably the short persistence of this construct that using CD28, as this is NIH study, they are using CD28 as co-stimulatory. So most of those patients, they consider CAR T-cell therapy as a bridging to transplant, and they receive transplant followed after CAR T-cell in most of the patients, compared with Kymriah, which it has 4-1BB, so more persistence. And they claim that in several patients, it is stands-alone therapy. But I think we need to follow those patients for more time to see is this right or not. This is another meta-analysis addressing long-term response for all types of CAR T-cell, including 4-1BB constructs, CD28, clinical trial, commercial. As you can see here, the survival, event-free survival, start to plateau after 4 or 5 years. So this is probably the event-free survival for most of the CAR T-cell till now, that they will have around 40% event-free survival. So that's why people start to think about post-CAR T-cell therapy, stem cell transplantation consolidation, because of the emergence of relapses in a significant number of patients. And whether stem cell transplantation will prevent relapse or not, still really there is no head-to-head studies to address this question. But this is really a publication that addressed the high and low risk group, intermediate group. So I think it's quite good approach if you adopt it. Low risk, if you have all these criteria, age more than 1 year, you don't have high risk cytogenetic like KIM2A, no previous blina or ENO exposure, and T-cell product containing 4-1BB is not CD28, and MRD negativity and day 28 by NGS, and long-lasting B-cell aplasia. If you don't have those lower criteria, probably you will fit in the intermediate risk or high risk. So just focusing with the high risk group to start with. If you have one or more of these criteria, then probably stem cell transplantation is justified in this subgroup. MRD positivity at day 28 by flow, or NGS positivity at 3 months or more, or any MRD later on in the bone marrow, or early loss of B-cell aplasia less than 3 months. So in conclusion, CAR T-cell therapy is an effective treatment options for patients with refractory relapsed B-cell ALL. CAR T-cell therapy must be delivered only in certified centers that were trained really to mitigate the toxicity profile of this kind of therapy. Our patient Ahmed is the first CAR T-cell therapy case in the Middle East and Africa, and he is now 2.5 years post-infusion and disease-free. Currently, we have 2 pediatric certified CAR T-cell therapy in Saudi Arabia. Our local experience demonstrates comparable efficacy and safety to those seen in the registration trial as well as real-world data study. Post-CAR T-cell relapse remain the major cause of treatment failure. However, post-CAR T-cell consolidative stem cell transplantation is needed in a certain subgroup of patients. Real-world high-quality data and longer follow-up is still needed, and there is a need for better CARs with better persistent and prevention of clonal escape. And with that, I would like to thank our teams at King Faisal Specialist Hospital, pediatric and adult, and also from DBLM staff for their really dedicated work. And there were huge efforts really done by those people and from nursing department, different medical departments. And also, I would like to thank our patients' families for their trust in conducting the first CAR T-cell and carrying on subsequent cases. And also, I would like to thank you for listening, and I'm happy to take any questions. Thank you.
Thank you, Dr. Ali. I think we just have a little bit of constraint of time. It was really an excellent talk, and congratulations for all your achievements and work in King Faisal. Really, we will have some time for discussion at the end of the session. I believe because Prof. Dider Blaise is waiting online. Prof. Blaise is professor in hematology at Marseille University. He's a director of transplant and cellular therapy immunotherapy program in Marseille, and he's well known and contributed to the field with more than 600 peer-reviewed publications. He's gonna debate today and talk to us about the haplo versus MUD in high-risk AML. So please, Prof, it's all yours, and sorry for the delay.
Thank you very much for your introduction. Dear colleagues, dear friends, it's a real pleasure to be with you today and to participate to this annual conference. I will thank the organizing committee for inviting me to address this question of a haplo donor versus unrelated donor transplant in high-risk AML. I have no real conflict of interest concerning my topic of today. And I do think that really to take the impact, to measure the impact of the questions that I will try to address today, we have to put that in the frame of the allogeneic transplantation travel over the 60 or 70 years since the early beginning in the mid-50s. In fact, we have to realize that the first HLA match transplant for acute leukemia in humans has been reported in 1971 by Dean Buckner for the Seattle group. So it was 15 years after the early beginning of transplantation. And starting on this time, HLA matching for transplantation has become either a major limitation or a big issue. And the reason is because donor is really the cornerstone of transplantation. And as you know, very few patients finally have a matched sibling donor available for transplantation. In a country as my country, with a sibling as with the number of 2 or 3, the probability is under 25%. So it took some time, and in fact, it took 10 years after the first report of HLA match transplant to have the possibility to address this question of lack of donor. And in fact, two strategies was developed. The first one was to try to find HLA match unrelated transplant, and the second one is to find within the family mismatch related donor. So the first report on unrelated transplant for acute leukemia has been once again reported by the Seattle group by John Hansen. And at the conclusion of this case report, the authors stated that it was feasible rather than genotypically HLA identical sibling, but it was probably available for the patient who will have common haplotypes. On the other hand, the first report on mismatch transplant made by Ray Pauls in London show not so promising result. On a series of 37 patients, if I remember well, the rejection rate was around 29%, and the grade 3 to 4 acute GVHD was 80%, conducting to a high non-relapse mortality at 1 year of 54%. And because the best result was achieved in CR1 AML young patient, Ray Pauls at this time says that the probable benefit of this kind of approach could be only in young patients with CR1 AML. And you know the present reality showing that 40 years ago, it was very difficult to predict what could occur. Starting in 1980, so at this time, there have been many improvements in allogeneic transplantation. But the real breakthrough concerning the topic of today occurred by the end of the 1990s with the possibility to do DNA-based HLA typing. And it is something indeed very important. In fact, if we look to one of the first report on a large series of patients receiving an unrelated donor transplantation, you can see that the main problem of this kind of approach is the occurrence of toxicity related to severe acute GVHD. Of course, this could be overcome by the use of T-cell depletion of the graft. But you know, as I know, that this kind of approach is associated with a loss in terms of disease control. So trying to get a really match donor to do the transplant was appealing, and the possibility to do this kind of high-resolution matching was of importance. And in this report from 2007, you can see that very clearly, whatever the disease, early disease, intermediate or advanced disease, it's better to have a good match to achieve good outcome rather than to have a partial match. So that was something very important, opening the gate to have less toxic transplantation. However, this kind of approach have a drawback, because not all patients can find this kind of good match donor. And for example, if you look to the probability of such a success, classified in different from high to low, according to the frequency of HLA-DRB1 allele or the frequency and the frequency of DRB1, DQB1 haplotype, very frequent here, giving a high probability of finding a donor, going down to low or very low. The results are very interesting. In fact, for the majority of the patients, you are in this situation of high probability, and you will find a donor in 78% of the cases within 20 days in median, which is not so bad. However, if you are not in this situation of high probability, the figures are not exactly the same, as you can see here, going down to less than 20% for the patient with a low probability, and with delay from 50 to nearly 500 days. And you have to keep in mind that this analysis was performed in German transplant centers. And it is important because most of the patients that have been included in this study were white Caucasian. And indeed, if you look to the probability to find a good donor in the US, for example, it's around 75%, the same numbers that what I have shown to you in the German study. But for other minority or other population, it is not the case at all, going down to 16% or less than 50%. So we have to keep that in mind. Not all the population can benefit from a match unrelated donor. On the top of that, there is something also which is important, is the fact that worldwide the odds are not the same. Here in this analysis of activity, evolution of activity in terms of allogenic transplantation between the year 2000 2016 for related or unrelated donor transplant, you can see here that there have been an increase in terms of transplantation. But this increase was basically overall the same for related or unrelated. But when you look to the different parts of the world, it was not the same. You can see here, if you compare figures for European countries, that in fact there was a huge increase in terms of unrelated donor transplant. And it was the case also for North America or Southeast Asian region. But for Latin America or Eastern Mediterranean region of Africa, the increase was related to related donor transplant, but not at all for unrelated donor transplant. Meaning that probably the procurement of the unrelated graft is much more complicated in this country. And we have to keep that in mind when we want to evaluate the possibilities of treatment. So what about the evolution and the result of allogenic transplantation for unrelated donor? In fact, in this interesting report from Anon Nagler from the Acute Leukemia Working Party of the BMT, you can see that on more than 3,000 patients who have been studied between the first decade and second decade of this century, there have been a nice evolution in terms of improvement for leukemia-free survival or overall survival. Of course, the numbers are low, but remember, all these patients have very high-risk disease, either primary refractory disease or relapse disease. So it means that really, and perhaps due to the fact that we can better match the donor and the recipient, the outcome has improved. Despite this improvement, there is still a medical need. Indeed, as I've shown to you, really, the transplantation cannot be performed in nearly a quarter of the white Caucasian, much more in the other population existing in different countries, and even less in patients living in countries as Africa or Latin America. So in this context, the possibility to do related haplo-mismatch donor transplant is very important because, as you can see on this schema, you open the possibility to find different kind of donor. And in fact, it's only at the beginning of this century that the reality of T-replate allogenic haplotransplant become a reality, both in China and in the Occidental countries. In China, Professor Wang developed a strategy using high-dose pre-transplant EG and high-dose myeloablative conditioning regimen, and with very interesting success. But I will not cover this aspect because I have no time to do that. But it's rather what we use in the other part of the world based on the use of cyclophosphamide after transplantation that I will focus my purpose. And this has been developed at the Johns Hopkins by Paul O'Donnell, Ephraim Fuchs, and Leo Lustig in Baltimore. And indeed, the post-transplant cyclophosphamide had a long story. I have been very fortunate some weeks ago to meet with Milivoje Boranik, which now a young adult of 83 or 85. He is a Croatian doctor who, in fact, published in 1971 the use of cyclophosphamide in a mice model and shows that using this cyclophosphamide after transplantation could conduct to discriminate between the GVL effect and the GVHD reaction. So it was 50 years ago. A little bit later, in Japan, an author, Mayumi, showed that the use of cyclophosphamide post-transplantation was important to induce tolerance. But it's really after the work reported by Leo Luznik that the possibility of using PTCY in clinic was important. And I have to insist, in this situation, it's high-dose PTCY, which is very different from many other experiments that have been performed before. I will not review in detail the mechanism, but you know that very well. In fact, when you give a dose or 2 doses of cyclophosphamide on day 3 and 4, you will eliminate the alloreactive T cells that have been proliferating after cell infusion, but you will spare the hematopoietic stem cell and the non-reactive T cells that at the end of the day will repopulate the patient. So many reports have been performed concerning haplotransplant and in different disease, in different age, with different conditioning regimen, with different graft cells, but they all conclude to the same thing, that it's PTCY, high-dose PTCY in haplotransplant is very efficient to prevent severe and acute and chronic GVHD. And it is important, notably for older patients, this aspect of preventing chronic GVHD. And it's the reason why, in fact, the evolution due to the possibility of better unrelated transplant or more matched unrelated transplant and the possibility to do this mismatch transplant has conducted to a huge increase of allogenic transplant activity worldwide. In Europe, at the present time, 50% of the transplant are performed from an unrelated donor, 20% from an haplo mismatch donor, and it's basically the same numbers in North America. But in some centers, as in my center, the figures are not exactly the same. We transplant many more haplo patient with haplo donor because we deal with an older population. In our center, the activity in terms of haplo transplant reach 60%. So now if we go try to compare allogenic transplantation from an unrelated donor and haplo donor, I do think that these meta-analyses on more than 20 different studies which have been selected, including more than 20,000 patients, is very informative. As you can see here, if you look for the non-relapsed mortality, clearly the patients who have received haplo with PTCY are doing much better than the mismatch or the match unrelated donor transplant. For post-transplant relapse, it's not exactly the same. At least there is no difference for mismatch unrelated donor transplant. But in terms of unrelated transplant, it's basically in favor of unrelated donor transplant. In fact, you have to recognize, and I have to recognize, that it's retrospective studies with many differences in terms of population, many differences in terms of procedure of transplantation that could induce real biases. Is the reason why we decided in France to set up a prospective randomized study on the search, and I insist on this point, I will come back to that, on the search of an haplo or unrelated donor to do allogenic transplant in patients older than 55. In fact, the trial was quite simple. At the time when we knew that there was no matched sibling donor, the patients were included in the study and randomized for an unrelated donor search or an haplo donor search. If unrelated donor transplant was performed, the patient received this conditioning regimen with ATG as GVHD prophylaxis. If the haplo transplant was performed, the patient receives this little bit different conditioning regimen and received PTCY as GVHD prophylaxis. We randomized 106 patients in 2 arms. And if you look to the population that have been included, you can see that the median age of this patient is 65. 80% of those patients have myeloid malignancies, and the DRI at randomization was 40% high or very high in both arms. And at the end of the day, in this intent to treat analysis, analyzing the outcome from the date of randomization, you can see that there is no difference in terms of progression-free survival. However, some details are of importance. As you can see here, if you look for an unrelated donor, you will find this unrelated donor only in 50% of the case. And it is the same figures for the search of an haplo donor. So only half of the patient in both arms will receive only the targeted donor. Of course, we allowed for crossover, and you can see we can rescue around 20% of the patient. And the reason for crossover was not the same from a group to the other one. If we want to look for unrelated donors, the main reason not to do this kind of transplantation was the absence of this donor. When we wanted for an haplo donor, the main reason to go to unrelated donor was the fact that the donor we tried to find was contraindicated. And remember that in the haplo situation, the donors are not pre-screened, which is a difference with the registries. But at the end of the day, you can see that in both arms, a quarter of the patient didn't receive the transplantation. And the main reason for that was relapse or progression prior to do the transplantation. And this is an important message, because you can imagine that it is an urgent indication to do the transplantation, but any delay going to this transplantation will increase the proportion of patients relapsing. Now, if we look to the patient who have been really transplanted according to the transplant they received, and looking to the outcome from the time of transplantation, so we can compare 77 patients. We have basically the same characteristics than in the intent to treat analysis, except for something. Time to randomization, from randomization to transplantation, was much longer, 20 days, in the mud transplantation as compared to the donor, haplo donor transplantation. And on the top of that, you can consider also that if we need a crossover, and you compare the patient transplanted with the first donor and the one who needed to have a second cell, you extend the delay to transplantation of nearly 40 days. So these two parameters, time to transplantation, analyzing the time to transplantation, are very relevant when I come back to the figures of 16% of the patient who didn't get any transplantation because of relapse. Now, at the end of the day, as you can see here, no difference in terms of outcome, whatever the outcome you look for the patient who have received haplo or donor transplant. So now, when you address this question of haplo versus unrelated donor transplant, HLA perhaps doesn't seem to be the best criteria. Other parameters are important. I have no time to review everything, and I will focus on 2 or 3 slides on the age of the donor and also on GVHD prophylaxis that I think are very relevant for the topic of today. In fact, age is something important. Many years ago already, it has been reported that an younger donor will conduct to better outcome in the situation of unrelated donor transplant. And it is the case also in haplo transplant. In a recent study we performed with Dr. Mariotti in Milano, combining the data from Marseille and different Italian centers, we have been able to show that the non-relapse mortality was increased with an older age, as well as the progression-free survival was decreased with an older age. And on the top of that, the relationship between donor and patient is also of a very high in patients with worse outcome for when the donor is a parent. Now, if we look if you try to answer to the question, is it better to have a young mismatch haplodonor or an older fully matched unrelated donor? I do think this study tried to answer this question. What I can say at least is that there is no disfavor to use a young haplodonor as compared to older adult unrelated donor, as you can see here, whatever the outcome you look at. So GVHD prophylaxis is something important. In all the studies I have shown to you, PTCY have been used for haplo, and it become to be more interesting in match-related donor. And in fact, the question is, will PTCY change the pattern of allogenic transplantation in the HLA match transplant? In fact, Eolia Brissot from the Saint Antoine Hospital set up this prospective trial in France, where patients with an HLA match were randomized to receive either cyclophosphamide or ATG. And as you can see here, at the end of the day, for GRFS, which was the primary question, there is really no difference. So I'm not sure that PTCY will change anything. Cost effectiveness and cost is also something that could be of relevance for the patient in some part of the world. You can see that transplantation from an haplodonor is cheaper than from an unrelated transplant. For half of the reason is the graft procurement, but in terms of cost effectiveness, unrelated haplo is also much more cost effective than unrelated transplant because the results are not so different. So in conclusion, I will try to give you at least my truth, and I will say that MUD and haplodonor will give the same outcome. Largest prospective studies are in favor of that. We have performed this prospective study in older patients. The problem is that real world interfere with the a priori medical choice of the donor. First, only half of the patient receives the desired treatment. A quarter of them will not proceed to allo transplantation because mostly of relapse. So the delay to transplant have to be taken into account, and it's sure that haplodonor identification is more rapid. And if you don't look for any donor at the beginning of the story, you will lose more days for some patients. Haplodonor has enlarged the possibility of transplantation. Most patients have a donor, but many patients, and I do think that's very important, several donors, allowing for a fine-tuning of donor choice on different other parameters, and notably the time to identify the donor. So it's really the door open for a personalized medicine in our practice. So I will thank all the people working with me in Marseille, in our department, and notably Régnier de Villiers performed some of the analysis I have shown to. And now I would be ready to answer any question if you are. Thank you.
Thank you very much, Prof. Day. We'll open for one or two questions if there's someone in the podium.
Thank you, Professor, for your nice talk. I was just wondering whether you found in your study any informative outcomes in if there is a leader peptide mismatches in the haplo patients. I know that it has some effect in the match unrelated mismatched donors. Do you think it might have an effect in the haplo patients?
Most probably, I do think there will be an impact. In fact, I'm not sure that we'll be able to find anything because the numbers are low. Let me make me very clear, I do think that a fully matched donor is probably the better situation in terms of toxicity. However, to find this donor, there is other limitation and other parameters that will make this choice very difficult. So in a practical way, we would say that whatever the donor we can find, what is important is what the donor at time of transplantation. After, we can elaborate on the quality of that. And I didn't elaborate neither on the degree of mismatch for haplotransplant. Would could be of importance also.
Any further question, Dr. Asker?
Yeah, Dr. Blaise, this is Ahmed Asker. Thank you again for elegant talk. Yeah, that's good enough. I don't know if I missed this or not. How about the PTCY in mud? Would that, do you think, improve the mud?
As I mentioned, the study reported by the Aeronia research, the publication is not yet done, but it has been reported in different meetings, showing that in fact, in the situation of HLA match, combining a related and unrelated donor, there is no advantage in terms of GRFS for the use of PTCY as compared to 2 days of ATG. So it may be different from unrelated or related. I don't know, I have not the details of the rule analysis, and we will send the publication. But basically, we didn't see any differences so far.
Thank you very much, Prof. Blaise, and I think now we'll switch gears and move to the next speaker. The next speaker will be Dr. Emanuele Angelucci. He is Head of Hematology Cell Therapy Director in San Martino in Genoa, Italy. He's also well known in the field of hemoglobinopathy and had a lot of publications in the field, including thalassemia, iron overload, and the talk today will be about gene therapy and hemoglobinopathy. So thank you very much, Dr. Angelucci, and welcome.
Thank you, Mr. Chairman. Can you see my slides? Can you see my slides? Sorry.
Yeah, very good. Yes.
Okay, thank you. Sorry. So thank you, Mr. Chairman, and thank you for the organizer to the opportunity to be here by remote with you today. And my talk is on the new development, new therapeutic strategy is in hemoglobinopathy, in sickle cell and thalassemia, which is gene therapy. It's a long-awaited gene therapy. This is my agenda. This is an introduction as a gene therapy finally comes to clinical practice. I will report current result already published, and I focus my presentation on the result presented at the recent EBMT meeting in Paris, and finally a brief comment on the hardness of adoption of gene therapies as a widely used curative approach in hemoglobinopathies. Okay, gene therapy means in this we are talking about congenital disease, and in this case, gene therapy is based on the transfer of a therapeutic or working gene into somatic cell of an individual in order to repair a defective gene copy. This is may use to replace a faculty gene or to introduce a new gene whose function is to cure, or sometimes further modify the clinical course of the condition. So the message is it's not simply necessary to correct the disease, the gene, the non-functioning gene, but it's necessary to have a clinical benefit for the patient. Sorry. Okay. Excuse me. Okay. In this condition, which is a congenital disease, what are the key to success of a gene therapy? As a high titer vector,
and the efficient transfer into target cells. We are talking here of the stem cells with an efficient engraftment of the traducer cell and the maintenance of stemness. This is a different issue than the CAR T cells. And we need an adequate persistent level of expression of this transgene, and we need to prove clinical benefit, correction of the disease in all its aspects. We see this particularly for what regards sickle cell, and of course, safety. The story is very long. It comes from a very long time, and the gene therapy is a natural prosecution of allogeneic transplantation in this form of the disease, and the story comes from several decades with a lot of improvement, but there are even several failures. The most important failure of the problem of this strategy was registered almost 25 years ago in a patient treated for primary immunodeficiency, in which in those patients there was registered a huge number of leukemia due to the vector. Following this event, which were regularly reported in the scientific literature, a lot of research have been done to correct this problem. It has led to the generation of much safer targeted vectors, such as self-inactivating gamma retroviral or lentiviral vectors. And there are also several studies, several research. The most important of them are reported here, which demonstrate safety and potential improved efficacy of this novel curative approach in hemoglobinopathies. But what is important to understand in this context that in this case of congenital inherited disease, the gene transfer has to be done in the hematopoietic stem cell, but the expression of the transfer gene has to be explained its efficacy just in the erythroid system and not in the other system. So we have talked about CAR T cell. In CAR T cell, it has to be modified the mature T lymphocyte. In this case, the modification is inside the stem cell, the hematopoietic stem cell, but its expression is just in the erythroid system. That's the two major diseases of transfusion-dependent thalassemia and sickle cell disease. So in this case, we need the gene therapy can have must prove to make a correction of the disease and to make clinical benefit. What does it mean? In thalassemia, and this is different from thalassemia from sickle. In thalassemia, gene therapy has to cause adequate production of beta or gamma globin. This is to reduce globin chain imbalance, is the key of the pathology of thalassemia, and to obtain normal to have a normal transfusion dependence of hemoglobin, normal hemoglobin, of hemoglobin, fetal hemoglobin. So to obtain the clinical benefit is obtain transfusion independence, but this is not enough. The patient has to have shown absence of ineffective erythropoiesis and stigmata of ineffective erythropoiesis. So to have a very real, clear clinical benefit. This is different in the situation in sickle. In sickle, gene therapy must obtain at the same time adequate production of beta or gamma globin, and subsequently normal adult hemoglobin or fetal hemoglobin. And this hemoglobin must be able to dilute sickle hemoglobin at a not relevant clinical level, for example, like a sickle cell trait. And consequently, the clinical benefit must be absence of venous occlusive crisis and other sickle cell stigmata, which are more general there are more than single venous occlusive crisis. There have been developed two different potential methods for permanently modifying hematopoietic stem cells. The first is gene addition. This is done using viral vector and consists in adding a copy, in this case, of beta globin gene. For example, we will talk of the gene able to produce hemoglobin AT87Q. Second method is genome editing. This is done using a gene reprogrammable nuclease, not a viral vector. And this method is consists in generating a de novo mutation that result in persistence of fetal hemoglobin in the adult life. So the first published clinical evidence of benefit of gene insertion in beta cell has been recently published by Franco Locatelli in the New England Journal of Medicine. 23 patients were consistent in the trial, 22 were presented, and transfusion independence was obtained in 20 of 22. This with patients with non-beta 0, beta thalassemia, transfusion-dependent thalassemia. Average hemoglobin obtained in this patient was almost 12 grams per deciliter of total hemoglobin, and a large part of this hemoglobin, almost 9 grams per deciliter, was constituted by the hemoglobin produced by the gene inserted inside the cell, and this patient obtained transfusion independence. And the methodology is, this is an ex vivo gene therapy, so it requires mobilization of the cell done by GCSF and plerixafor, apheresis, central manufacture with insertion, return to the cell, modified cell to the center, a busulfan myeloablative regimen conditioning the patient without immunosuppression. This is just like on the clinical course is autologous transplantation, product infusion, and follow-up, even long-term follow-up. This is the result published in this paper in this category group of patients. On the bottom of this slide, you can see a graph reporting in blue line the total hemoglobin of this patient, and in the red line the hemoglobin produced by the inserted gene, and the old patient presented transfusion independence. This is the result of the study. The published study demonstrated efficacy of this kind of gene therapy. In the latter graph, you can see median percentage of lentiviral vector positive cell in the beta cell, and in the bottom of the slide, the vector coupling number in the beta cell at 6 months after transplantation. These results were obtained in the first published trial in non-beta 0, beta 0 thalassemia, but after modified manufacturing, same result have been obtained even in beta 0 thalassemia. Really important on the clinical point of view, as shown in this slide, that this patient demonstrated an absence of very limited and ineffective erythropoiesis, as demonstrated by soluble transferrin receptor, which is a marker of ineffective erythropoiesis in patients who would acquire transfusion independence. So these patients were really cured of their disease, and the same effect as can be demonstrated by this slide showing on the left a bone marrow patient before the procedure with clear sign of a very large expanded erythroid system with a sign of ineffective erythropoiesis and an almost normal marrow 12 months later, and the same effect of suppression of ineffective erythropoiesis is demonstrated on the right part of the slide by the ratio between the myeloid and erythroid ratio, even at the same time 12 months after gene therapy. The second approach, and I will focus on this approach because this approach has been presented by Franco Locatelli at the recent EBMT meeting in Paris, is the gene editing. Gene editing is based on the clinical impact of gene editing is based on two observations, clinical observations. The first is the hemoglobin switch, which happens a few months after birth. In the fetus, the hemoglobin is fetal hemoglobin. It's constituted by alpha and gamma chains, alpha 2, gamma 2, which became, and early after birth, production of gamma cell is suppressed and upper production of beta cell, leading to the adult hemoglobin, which is alpha 2, beta 2. The second observation is that, clinical observation is that patients with thalassemia who present at the same time hereditary persistent hemoglobin F seen into adulthood present a less severe disease without any detrimental effect. So which means that hemoglobin, fetal hemoglobin, even in adult life, is a good hemoglobin able to guarantee a normal life. So the approach is by gene editing is disruption of the erythroid enhancer region of the BCL11A, which this disruption lead to the re-expression of the globin, of the gamma globin, and the production of hemoglobin F. So this the destruction, the suppression, permitting the persistence of the production, the reappearance in this case of the production of hemoglobin F. Even in this case, this is an ex vivo procedure, require mobilization. Mobilization in sickle cell disease is obtained at the same time with GCSF and Prerixafor. It requires apheresis, central manufacturing by CRISPR-Cas9 modification, return to the center, a myeloablative regimen. Even in this case, this is like an autologous transplantation, infusion, and follow-up. The trial is called CLIMB trial, thalassemia 111 trial. At the recent EBMT meeting, have been presented 44 thalassemia patients. Mean age was 21 years, and the range was 12 to 35. On the right part of the slide, you can see the drug product cell dose, which was 7.5, and then the time to necrophil and platelet engraftment, which was 29, respectively 29 and 43 days. So the recovery of polyps and the recovery of platelets is longer than in traditional hematopoietic cell transplantation, but even in this case, long-term recovery is completely. In data presented at the follow-up of 1 year. And most important in gene therapy is safety. You see the adverse event reported in these 44 patients, mostly were related to the myeloablation of the conditioning regimen. All of them are very well-known adverse event. There was particularly related to XSL, the product, was a case of hemophagocytosis with characterized by macrophage activation syndrome, acute respiratory distress syndrome, headache, and interstitial pneumonia, all in the same patients. All this this adverse event began pre-engraftment during the aplasia, and occur in the context of hemophagocytosis, which was the start of the whole problem. Because all the events fully recovered with steroid and immunosuppressant treatment. One patient presented with thalassemia presented adverse event related to XSL and bisulfite was the Leiden neutrophil engraftment and prolonged thrombocytopenia. Even in this case, the adverse event fully recovered with the follow-up. Even the result, you can see in dark blue the level of hemoglobin F produced during the follow-up. You can see by starting from the second month, almost all these patients presented transfusion independence, and a large part of their hemoglobin was hemoglobin F produced by the transducer stem cells. And if you look at clinical benefit, the transfusion independence, when you see that 42 of the 44 patients with more than 90% stopped at the red blood cell infusion, transfusion, and acquired transfusion independence. At the time of this analysis, 2 patients had not yet completely stopped the transfusion requirements. You can see really important, we look at the cell, we can see that it was demonstrated the pancellular expression of hemoglobin F. And if you look at editing BCL11A editing bone marrow on the left and the peripheral blood on the right, you can see that after the third period, there was a very stable editing of the BCL11A. And if we look at sickle cell, as regards to sickle cell, Professor Locatelli presented 31 patients treated with this approach. Mean age was 22 years and the age range was 12 to 34. All of them had severely symptomatic sickle cell disease. In this case, cell product was less than in thalassemia. We will see later the reason was 4. And even as in thalassemia, neutrophil and platelet recovery was a little delayed, less than in thalassemia, was 27 days for neutrophils and 32 days for platelet. The duration of follow-up for sickle, mean duration of follow-up for sickle was 10 months. Even in this case, this is an ex vivo gene therapy requiring mobilization, and in this case, mobilization is done only with plerixafor because of the risk of venous occlusive event with the use of growth factor, and this is the reason of the less number of obtained transduced CD34 positive cell. Even in this case, there is the apheresis, central manufacturing, a return to the center, and even in this case, a myeloablative regimen with busulfan infusion and follow-up. Important to look at the primary endpoint of this trial, and the primary endpoint as regard efficacy was proportion of participants who had not experienced any severe venous occlusive event, venous occlusive crisis, for at least 12 months. This is in the study, starting from day 60 after last red blood cell transfusion up to 24 months after product infusion. Then you see as a primary endpoint the safety endpoint. Of course, there were several secondary endpoints, but we just focus on the primary endpoint during this presentation. As regards adverse event, even in this case, a large part of almost all the adverse events were related to conditioning regimen, which was the same than in transfusion-dependent thalassemia, and safety profile was clearly consistent with the myeloablative conditioning and autologous stem cell transplantation. As to be reported that in this trial, one patient have died, but severe respiratory failure due to COVID infection several months after product infusion. It was a not vaccinated patient. Investigator defined this adverse event not related to exocel infusion, to exocel product. If you look at the clinical result, you can see the early couple of months, 3 to 3 months after the product infusion, there is a clear production of fetal hemoglobin that contributed to almost 50% to the total hemoglobin of these patients. So it was a successful engraftment with the production hemoglobin, fetal hemoglobin. And if we look what this was the primary endpoint, the clinical primary endpoint of this trial for regards sickle cell anemia, which is all the 31 patients at the data analysis of this part of the trial. All of the 31 patients presented were venous occlusive crisis free during the follow-up, of 1 year from 2 to 32 months. Clearly longer follow-up, a completion of the trial is necessary before a definitive conclusion. Even in this case, hemoglobin, production of hemoglobin F was pancellular, and even in this case, BCL11A editing was stable and consistent in all the cells, in bone marrow and peripheral blood cells. I want to conclude my talk just discussing very briefly with you what I consider this is very extraordinary result. We have considered the hardest to wider development, wider diffusion of this curative approach, which is long-term adverse event, which of course require longer follow-up and pricing and problem of the cost. It should be mentioned that inside the gene insertion program, the gene insertion and the gene editing program have been registered 2 cases of acute myeloid leukemia. Initially, there were 3 cases, but following investigation, one case was considered not related to the procedure, but related to a pre-existing patient situation, where there were 2 patients of acute myeloid leukemia. In one case, the vector was not found inside the blood cell, but in the second case, patient 3, the vector was found inside the blast cell. Further investigation led to the conclusion that there was not causative this insertion, that the program was restarted. And we have to, it's an important consideration, this event were registered just in sickle cell disease and not in thalassemia. And we can see that sickle cell patients present at a higher risk compared to normal population of acute leukemia, even if the incidence is less than was reported in the few cases of gene therapy in this disease. There is a large California study and a large UK study reported the risk of acute leukemia, acute myeloid leukemia in this category of patients. Clearly, in my opinion, is that further investigation are necessary in this field, particularly in the field of sickle cell, just to define the main risk factor. It should be so I think that should be investigated increased inflammatory condition that presents in this category of patient, eventually relationship with the conditioning regimen or the preconditioning regimen of the pre-gene therapy or with the gene therapy itself. That clearly more investigation are necessary. The second problem is what is called financial toxicity. This is clearly an expensive procedure, and value probably is clearly defined by cost and price has to be clearly defined. It has to be reported that in 2021, after approval by HEMA, and this was regarding gene insertion, there was a lack of economic agreement between the manufacturing company of the gene insertion program and the German regulatory authority. Germany is the first country in Europe that can have commercial authorization after EMA approval. And this lack of agreement led to closure of the company activities in the European Union with consequent not availability of the product in Europe. At the bottom of the slide, you can see the official press release by ASH. This is clearly a problem. At the moment, I have not information about possible cost of the gene editing products. Finally, I want to make a comment. This is our fantastic products. It is a fantastic step forward in our possibility to cure hemoglobinopathies. Hemoglobinopathy is a congenital disease, and the proof of the possibility to cure the disease has been done by hematopoietic stem cell transplantation several years ago. But sometimes people and patients can believe that medicine are enough, but for this reason I want to remember this statement by Dr. Carl Gustav Jung: the medicine can cure disease, but only doctors can cure patients. And with this remembrance, I thank you for your kind attention.
Thank you very much, Dr. Angelucci. And we'll have time for one or two questions as well.
Hello, Dr. Angelucci. It's a real privilege to have you with us today. My question is about, I think more and more we're seeing geographic disparity in terms of access to novel and innovative therapies, and I think it's probably, as you said, going to take a while to actually commercialize this product and have them available to our patients. But I was wondering, similar to what we're seeing with transplant, where we have the Pizarro classification that we use to kind of predict transplant outcome, what do you think would be the ideal patient setting if we were to have this product? Who would be prioritized, so to speak?
Oh, this is, thank you for your question. Let me say the privilege is mine. I think that as physician, we will have in the next few years this challenge. So to find and to determine which would be the best option for our patient on an individual basis. We have, there will be several conditions to be considered. Availability of the products, availability of the donor, adverse event, resources, resource availability, age of the patient, clinical condition of the patient. The study of transplantation clearly says that clinical condition of patient is the key of allogeneic transplant success. I think this is the same will be for gene therapy. This means that unless the curative approach can be done to our patient, we have to make all the effort to have a very regular, very good transfusion and iron chelation therapy for our patient, and the way they can approach the curative treatment, allotransplantation, our gene therapy, in the best condition. And in this way, we can have the best results. But what we have to done in the next few months and years is to find out selection criteria, priority criteria for approaching gene therapy for the condition of patient, taking into account the problem of the price and the problem of the product availability. This is, I have not the definitive answer in this moment, but we are all, as physicians, we have to work all together to find the better way to a correct answer to your question.
Thank you.
Thank you very much. Thank you very much, Dr. Angelucci, and I think we'll move to the next talk, and hopefully next time you will be visiting us here in Saudi Arabia personally.
Sure. It will be an honor, my pleasure, and an honor for me. Thank you for your kind invitation, and goodbye to everyone.
Goodbye. So the final session is sponsored by Novartis. It will be done by Dr. George Cortes, who is the director at Georgia Cancer Center. Also, he's very well known in the field of the adult and the CML era. He's been working in MD Anderson for quite a good time. Published a lot of pioneer and peer-reviewed articles. He's also, as of early on, a member of the European Leukemia Net panel of the CML recommendations since 2006. And we are really privileged today to have him giving us this talk.
Thank you very much, and thank you for the kind invitation to be here with you. It's really an honor to be back in Saudi Arabia. I've been here one time before, many years ago, so it's really great to be back and to share with you some of the updates in chronic myeloid leukemia, how I see the management of CML, which continues to evolve and continues to evolve for the better. My focus today in this presentation is going to be on the guidelines and the importance of why we focus on these guidelines. And this is topical because we are right now working on the new edition of the European Leukemia Net guidelines. We're going to be meeting at the European Hematology Association meeting in a couple of weeks. Probably will be the last meeting before we start writing the manuscript. So it'll probably have some additional updates. These are my disclosures. So it is very clear to all of us that the outcome of patients with chronic myeloid leukemia has improved over the years, and you can see how the survival from the days where we used only chemotherapy to the introduction of interferon, and then with the tyrosine kinase inhibitors, it has greatly advanced that expected survival in something that we have not seen with too many other hematologic malignancies or cancers for that matter. And with that, we know that today a patient with a diagnosis of chronic myeloid leukemia, for the most part, can expect a normal life expectancy. That is that they can live as long as any other individual of the same age and the same characteristics. And they're probably not going to die of CML if we have the opportunity to give them a tyrosine kinase inhibitor, if we monitor them well, if we manage them well, and move them through these guidelines in the proper way. Now, there have been some dissents, and many times I've heard that some colleagues have said, well, yes, we introduced second-generation tyrosine kinase inhibitors as frontline therapy, but yet that did not improve the survival of patients. Well, that's very difficult to expect when you already have a near normal life expectancy with imatinib. But I think it is important to recognize that as we have improved on the therapy, and the ways to monitor our patients, we have evolved in the management of patients with chronic myeloid leukemia. First, we also need to recognize that this improvement in the overall survival that we see in very selected populations, for example, from clinical trials, from very specialized centers, has really not reached everybody. These are statistics from, on the left, from the MD Anderson Cancer Center. When I was working there, as you heard, I was there for 27 years before moving to Georgia. And on the right, this is the epidemiologic data from the United States that takes all of the population in the United States. And surely we have seen an improvement in the overall survival, but it's not nearly as good as we had seen at the MD Anderson. So there's still a lot of room for improvement. So why is it not as good in all of the patients that we have in the US? And I think that probably applies to many other parts of the world. Well, one of them, of course, is the access to drugs. There's many patients who really don't have access to drugs, so, even in the United States, and certainly in the parts of the world where the access, because of the cost and other issues, is not as good. But also because of the monitoring. The monitoring that I see happening in the community in patients that are referred to me is not optimal in all instances. And the management of patients, the opportune detection of treatment failure, the opportune change of therapy when it is indicated, we are really lagging behind on that. And that is part of the reason why many of these patients don't do as well as they could be doing. I also see that the dosing is not done appropriately in many of these patients. So you really want to optimize the dose for each patient to make sure that they get the greatest benefit. Of course, the clinical trials, in addition, have a patient selection. We select them by their eligibility criteria, and that makes them more fit than the average population with chronic myeloid leukemia. And then there's the adherence to therapy that may be faulty. So, but I think that what's very important to recognize is that the CML has evolved in many ways. The treatment has clearly evolved. Again, we started using chemotherapy when I was doing my fellowship. That's all I had. I started in Mexico. We didn't even have hydroxyurea. We only had the sulfide. Now we have many tyrosine kinase inhibitors. We also have much better ways to monitor the disease, from just focusing on a blood counts to going through cytogenetics, FISH, and now a quantitative PCR, and little by little moving to a digital PCR. With that, our endpoints have evolved. We don't focus only on hematologic or even cytogenetic responses. More and more, we focus on molecular responses, and particularly on the deeper molecular responses. And the goals have changed from just controlling the symptoms and improving survival to focusing on event-free survival, and more nowadays in treatment-free remission. So when you think about a patient that's newly diagnosed with chronic myeloid leukemia and you start the treatment, you go from achieving a hematologic response, a cytogenetic response, and a molecular response, and so on. But there are situations where you're going to identify that the patient is not doing well. Certainly when there is resistance or when there is intolerance, we know that we need to change therapy. But there are other instances that more and more we are starting to recognize that represent a challenge for the patient's long-term endpoints. Suboptimal responses, or what we call warnings in the European Leukemia Net, and low-grade toxicity, which also can be very damaging for the patients in the long term. And even patients who are not achieving a deep molecular response, when the endpoint, the goal of the patient is treatment-free remission, we are starting to think, should we be changing therapy for some of these patients? So the ELN recommendations have said very clearly the goals of therapy at given times and what constitutes then within each of these times an optimal response, which is what you see in green, and a warning, which is like an alert that we need to be aware of, and then a failure, which is a clear indication of therapy that if you recognize, you need to change immediately. For the warnings, there's a little bit of debate. In some instances, we choose to wait. But again, if your goal is to achieve deep molecular response and getting treatment-free remission, early recognition and early change is what's going to give the patient the best chance of doing that. In the US, there's the NCCN, so the National Cancer Center Network. These are the largest cancer centers in the United States. They come up with recommendations, and they're very similar to what you see with the European Leukemia Net. The big difference is that they only go into 12 months. They don't address what happens later on. But again, the emphasis is the importance of those early responses and why you need to recognize them early. You can see here, at 3 months, you already have a warning for the greater than 10% and a clear failure at 6 months if you're above 10%. And the recommendations, very similar to the European Leukemia Net, change certainly when it's a red and in many instances when there is a yellow. Now, that is for the frontline therapy. And the European Leukemia Net says you can use the same guidelines for the second line of therapy. So meaning a patient who took, let's say, imatinib, then you give a second generation TKI, you can use the same guidelines. We continue emphasizing the early responses in the second line. But one important thing that the NCCN guidelines mention is that once a patient has had 2 prior TKIs, usually there'll be imatinib and a second generation TKI. For second generation TKIs, I'm talking about dasatinib, nilotinib, or bosutinib. The use of another second generation TKI is really not recommended. You really should be focusing on either ponatinib, asciminib, or a clinical trial if that is available. So with all of these, there are different approaches to changing therapy. One is the reactive approach. That is when you change when there's clear evidence of resistance or clear evidence of intolerance. Of course, in that instance, we need to change therapy. That is very clear. Now, if that happens all of a sudden, well, that's all you can do. But if there are warnings before that, you can do a preemptive approach of changing therapy before this becomes a true failure to try to improve the probability of the patient having a good endpoint long term. And we need to remember always that we're looking at what the patient can achieve in the long term, not just how the patient looks in that context. And that's why more and more we are starting to look at ways to improve proactively and consider even some changes in at least some patients proactively, particularly when you're focusing on treatment-free remission. So let's look at some of the data that backs all of these reasons for changing therapy and changing opportunity. When you look at all the frontline studies, and I'm focusing here on the 3 main randomized studies of imatinib versus a second-generation TKI, imatinib versus dasatinib, dasition, imatinib versus nilotinib, an SND, or imatinib versus bosutinib, which is the before trial. As you can see, it is very consistent in all these studies. And keep in mind, these are very selected populations. And yet, by 5 years, 40% of patients, whatever they're using, imatinib or the second generation TKI, you can see it's very, very consistent that 40% of patients have already changed therapy. So as good as we think that these treatments are, already 40% have required to change therapy. And we have one study, the NSTD, that follows patients 10 years, and 50% of patients have required to change therapy. So many patients really will need to change therapy in the long term. You also remember that some years ago we established that the 3-month response then became very important. We are trying to identify these patients early on so that we can change their therapy and or do something to try to improve their long-term outcome. And in all of these studies, they showed us that patients that by 3 months have more than 10% transcripts, they do not have the same probability of a good progression-free survival. They do not have the same probability of overall survival in the long term. They're going to be okay for the next 3 or 6 months, but they're not going to be okay in the next 3 or 5, 10 years for sure. And it's very interesting when you look at the data that has been published, these 3-month response. On the left was that initial call to attention of this early molecular response from the Hammersmith. David Marine was working at the Hammersmith. And on the right, you see one example with one of these second-generation TKIs, in this case, the Decision study. And both of them show that if you have more than 10% transcripts, the overall survival is worse. But look at the difference in overall survival for these patients. Here, it's about 80%. Here, it's only about 50%. Why such a big difference? The main reason why there was this big difference is that at this time, the British authority had not authorized the payment of dasatinib or any second-generation TKI after failure for imatinib. So the change happened very late. And with that, that impacted the survival very significantly. Whereas not when in this setting, where you could change the patients very quickly to dasatinib, the survival, yes, it's worse because these are worse patients, but it's not as poor as the survival that you see in this other study. So what can you do for these patients then? There's only been one randomized study that has looked at changing therapy versus continuing on imatinib. That's the DASCERN study. This is a study that we presented at ASH last year. We're sending it for publication now. So patients who at 3 months have more than 10% transcripts while on imatinib, randomized to change to dasatinib or stay on imatinib. And as you can see, the probability of achieving a major molecular response long-term is better, statistically significantly better for the patients who switch to dasatinib. So if you're focusing on these deep molecular responses long-term, it may have a benefit. Now, we need to see more follow-up to see that those deep molecular responses really make a difference. There's not much of a difference in overall survival or progression-free survival, because the patients who didn't change at 3 months, they changed later on at 6 months or 12 months. This is a warning, not a failure. So it probably that makes a difference compared to that strategy by Marine of changing very, very late. But if you are focusing on a deep molecular response, it does make a difference to change at 3 months. And this is an analysis that we did many years ago, and which emphasizes that if you have more than 10% at 3 months, should the probability of major molecular response decreases significantly. But if you are by 6 months or by 12 months, look at how few patients are going to get a major molecular response over time. So the longer you wait, the lower the probability of a patient really achieving a deep molecular response. This is only major molecular response. Deep molecular response is even less. And the greater the risk of transformation or progression to an accelerated or a blast phase. So again, emphasizing the importance of early recognition of these phenomena. And here's what you can see for deep molecular responses. What I showed you in the previous slide was major molecular response. This is MR 4.5. And this is sustained MR4.5, what you need to consider a treatment-free remission. And you see this is by 3 months. These are the patients who are more than 10% at 3 months. And the longer the time, the worse the probability of achieving ever a deep molecular response. This is by 18 months. If you're waiting all the way to 18 months, really nobody's going to achieve a molecular response. And even less, a sustained deep molecular response. Now, what does achieving a major molecular response mean? Well, the major molecular response is important because it decreases the probability of event-free survival. So it doesn't improve the probability of survival. Again, the survival has already reached that of the general population, but decreases the risk of the patient eventually having to lose the response and requiring additional intervention. So that's what we focus more in these molecular responses. And even the deepest molecular responses. So in this study from Germany, from the CML4 study from Germany, clearly the survival is the worst for patients that have more than 1%. But the deeper the molecular response, the better the survival. Now, this is not statistically significant because the follow-up is short and the number of patients doesn't quite make it to provide significance. But you see the best curve is the less than 0.0032, and little by little it starts getting worse and worse, and it starts opening more the higher the transcripts. But more importantly, it really impacts the failure-free survival. And by failure means anything that requires a change in therapy. Of course, a transformation, a loss of molecular response, a loss of complete cytogenetic response. The lower the transcripts, the better the probability that the patient will not have to change therapy at all ever. So that's why we focus more and more on these deep molecular responses, in addition to the benefit for treatment-free remission. Now, we also know that when a patient has failure to a tyrosine kinase inhibitor, to their first tyrosine kinase inhibitor, their survival is not as good any longer, especially if you have if you don't have too many options, or if you wait too long to use them. This is very old data. Look, it's 2007, so this is 16 years ago. But this is when we started seeing patients on imatinib who had a failure. At that time, we didn't have yet widely available dasatinib and nilotinib, or all these other therapies. And you can see the survival, the median survival was about 5 years, meaning it started to look like the CML of old days before we had tyrosine kinase inhibitors. Of course, if they had moved to accelerated phase or blast phase, it was even worse. But clearly, this is not the kind of survival that we want to see today, that we can see today, because we can change patients to alternative tyrosine kinase inhibitors. And even in the second line of therapy, that early molecular response matters. So these are patients on dasatinib after imatinib failure. And again, the 3-month response greater than 10% has a worse survival than the patients that have a good molecular response at 3 months. We tend to think that we have a very good approach for patients who have failure to imatinib, that we can switch them to a second-generation TKI, and that the outcome is very good. Well, is that good? Is that treatment really that good? Look at the data from all these 3 drugs after imatinib failure only. This is the original data that led to the approval of all these drugs in this context. As you can see, the complete cytogenetic response is only 40%, 40 to 45%. It's complete cytogenetic response. That's not molecular response. It's just complete cytogenetic response, which is good, but it could be better. Nowadays, should be better. And even then, it's only 40%. Now, I'm showing the data here at 2 years because that's where we have data equivalent for all these studies. But if you look at the more recent data with 8 years, and for that one we have data with bosutinib, it has changed very little. It's gone up to 50% after 8 years. So at best, 50% of patients have achieved a complete cytogenetic response. So that tells us that, yes, that treatment is good and it's better than not having those alternative treatment options, but it's certainly there's room for improvement in this context. And also in these patients, we demonstrated again many years ago, this is 2009, the importance of switching early. See what happens when you switch. In those days, we were focusing mostly on cytogenetic versus hematologic response. PCR was not as well established. But the patients who switched after losing their cytogenetic response, they had the best outcome. Patients who switched after they had already lost their hematologic response, their outcome was not as good. So showing that early recognition and early switch was very important in this context. And that translated into much better event-free survival if you switched with early, and a better overall survival if you switched early as well. And as you go from a second TKI to a third TKI to a fourth TKI, it is very clear that the survival of these patients starts getting worse and worse and worse, and the transformation-free survival of these patients starts getting worse. So letting the patients go through failure really has an impact. It may not be immediate, but certainly it has an impact long-term probability of survival and of transformation-free survival. I mentioned earlier what the NCCN says about a patient that has gone through 2 TKIs, imatinib and a second-generation TKI. And this is mostly all of the reports that have used going to the third TKI being another second-generation TKI. And as you can see, the results are not very good. The probability of complete cytogenetic response is about 20 to 30% in almost all of these studies. And molecular responses are even worse. So in my opinion, going to another second-generation TKI after already having resistance to one second-generation TKI is what I call a lateral move. Yes, you can do it, and the patient may be stable for a little while, but you're not really giving the patient the best opportunity for a good response long-term. And that is reflected in a very poor survival. As you can see here, even in chronic phase, the median survival is less than 2 years. So clearly not what we want to see in these patients now that we have better treatment options. One of these treatment options, the first third-generation TKI, was ponatinib. Ponatinib was introduced with the PACE study. You all know about it, and it was effective, but it gave us the arterial occlusive events. So recently we did this study looking at the optimal dose of ponatinib to try to minimize the risk of arterial occlusive events. In this study, what we saw is that the best response rate was the 45 milligram standard dose, but reducing the dose once the patient reached 1% or less. There is more toxicity, arterial occlusive events in particular, which is the biggest concern that we have. There is more of that with 45 milligrams than with 30 milligrams. With this approach, it's not quite as high as we saw with the solid 45 milligrams that we were using in PACE, although we still need to monitor these patients carefully. One important element, and this is taken from the abstract, the full data is going to be presented at EHA later today, is that even in this context of patients who have received multiple prior therapies, early response still matters. Patients who have greater than 10% transcripts by 6 months, you can see that the probability of progression-free survival and overall survival is much lower. And I'm not going to go through the whole table, but that's the message that we can see even in this context. Now, patients who go through ponatinib and don't do well, their outcome, their probability of success is very poor. As you can see, very few patients will respond to additional therapies. This is in 2018. That's before we had asciminib, and their overall survival was very, very poor. Well, as I mentioned, now we have a new drug, which is not only a drug that also covers multiple prior therapies and T359, but the important thing is that it has a novel mechanism of action. Yes, it's a tyrosine kinase inhibitor, but it's not an ATP competitive binding inhibitor. All of the other tyrosine kinase inhibitors bind where the ATP binds in the kinase domain. This one binds in this myristoyl pocket,
which is important because, number one, it's not affected by most of the mutations that we see in patients. Number two, that myristoyl pocket is very unique to very, very few kinases in our body, which makes it much more targeted, much selective than the traditional tyrosine kinase inhibitors. You all are familiar with the data with asciminib in this study, where we started to see very high levels of response in patients treated with asciminib after multiple prior tyrosine kinase inhibitors, and even in patients that had received ponatinib previously. And again, one important thing, the patients that had switched to asciminib when their transcript was still relatively low, but they had already shown clear failure to the prior tyrosine kinase inhibitors, they do better. Again, the emphasis, early switch makes a difference. And that led to a randomized study of asciminib versus bosutinib in this context of at least 2 prior tyrosine kinase inhibitors. It demonstrated a significant benefit for asciminib with almost more than doubling the probability of major molecular response at 96 weeks compared to bosutinib. We did see a few arterial-occlusive events, but keep in mind that the exposure was much longer for asciminib. So you have to adjust that by the exposure. When you do that, that difference shrinks a little bit more, but much less than if you don't do the adjustment. Always have to look at the exposure-adjusted risk of these events. It is also, as I mentioned, very effective in T359 patients. Look at these major molecular response in almost half of the patients, and even patients who have received prior ponatinib have a very respectable almost 30% response to asciminib. So a very active drug, very effective in this context, and we are starting to look at different indications for ponatinib, for asciminib. So this is, in summary, how we sequence therapies. Of course, when in the first-line therapy, this is all of the drugs that are approved in the U.S., imatinib, generic imatinib, nilotinib, dasatinib, and bosutinib. And then for second line, we have all the other drugs. Now, I do think that for patients that have resistance to a second-generation TKI that was used as frontline, to me, what I do is I give them ponatinib or asciminib. I don't do another second-generation TKI. And then, of course, for third-generation TKI, the drugs of choice should be these drugs, ponatinib or asciminib, not another second-generation TKI. So now, is it that simple? Well, you know, for imatinib resistance, yes, we can switch to a second-generation TKI, but I already emphasized that the results are not great. So I prefer to use a third-generation TKI. We are doing studies with asciminib in this context because I think it can give us much better than what we are seeing with the traditional TKIs. Again, if the patients have received one second-generation TKI as frontline, I do think that the third-generation TKI is the treatment of choice. For suboptimal, right now, what we do is monitor closely. I think that early switch, and we'll see the long-term results of dasatinib, the CERN study, but it already shows some early benefits. In summary, when do I change therapy? Certainly when there's a clear failure by the European Leukemia Net definitions, when there's loss of complete serogenetic response, when there is intolerance, those patients you really need to change therapy. And even in many patients with suboptimal response, especially if it is a patient that's interested in treatment discontinuation in the long term. So my final words, one, just keep in mind that just being PCR positive, that's not a failure. That is not a scenario where I change therapy. But in 3 months, I am doing it. I do have clinical trials. And outside of a clinical trial, in those patients that I'm focusing on treatment-free remission, you need to know that you have something better. Again, not from one second generation to another second generation. You need to go to the drugs that are more effective in that context. There are some adverse events that we can manage, like diarrhea. Don't keep your best treatment options for later just in case. In cancer, you use your best drugs as quickly as it's indicated so that you can give the patient the best outcome. I don't leave anything for later on. Certainly, transplant is still a valid option for these patients. So in conclusion, I'm going to close with these words of Winston Churchill, who said there's nothing wrong with change if it is in the right direction. So we just need to make sure that we make the change in the right direction for these patients. And I want to just remind you of our CML conference that's going to be this year in Mandaloo in October 6 to 8. It's a beautiful place, a great conference. So hopefully we'll see many of you in that conference. So with that, I conclude. I thank you for your attention. I'm happy to answer any questions.
Thank you very much. And if you have questions from the audience.
Please, this is the Professor of Imam University. Just one of the questions regarding patient that is in the deep remission for 2 years and is a complete treatment for 3 years on TKR. Then he gets a progress later on the year and should be switch with another TKR or came back to the original one.
So the patient stopped therapy and then relapsed?
Yeah.
I usually would go back to the same treatment that they were receiving, unless there was enough, that part of the reason why I stopped was because there were side effects. If it was not very well tolerated, then I switched. But most of the time, I would come back to the same TKI.
Any further question? I think for the sake of time, I can invite Dr. Faiz to chair the next satellite discussions. So please go ahead.
Thank you very much.
Hey, Dr. B, how are you? This is myself. Not getting your voice.
afternoon. I'm not sure, Dr. P, are you hearing us?
صوت شوي دكتور.
Dr. Bimraju, are you with us?
Hey, how are you?
Hey, how are you?
Good.
So, good afternoon, everyone. It is a pleasure today to introduce Dr. Bimraju for this talk. Dr. Bimraju is no much of an introduction. He is an associate professor at the MD Anderson Cancer Center in the Leukemia Department, and he has been leading the efforts in the treatment of myeloid malignancy, MPNs, and he is the world leader in treatment of BPDCN, or plastic plasmacytoid dendritic neoplasm. Dr. Bimraju has led several trials, had led to he has under his arm the approval of tagrovosp, the SL 401 123 targeted therapy. He also is working on other agents in BPDCN, including the IMG and venetoclax containing regimens. Without further ado, I know Dr. Bimraju did take a lot of time today. He is on service, and in addition, he is having a clinic. So thank you very much, Dr. Bimraju, for being with us, and hopefully we'll have you with us in person next year. Before now, the floor is yours.
Wow, thank you, Dr. Mansour, for that very kind and warm introduction, and to be here with you and your colleagues, at least virtually, is an honor, and it is a great privilege for me to link up with you and all of our colleagues throughout Saudi Arabia, as you have been great partners and colleagues, and just really fantastic to work with over time. So thank you. Mansour, shall I share my slides?
Yes, please, go ahead.
Great, perfect. I have them right here ready to go for us. Okay, very good. So thank you all. Just a few comments here as we begin. I'd like to share with you our work and advances in the diagnosis and treatment of BPDCN, elastic plasmacytoid dendritic cell neoplasm, and hopefully as a reflections and extrapolation to some of the more common myeloid malignancies. As an active clinical trialist here in America, here are my disclosures. We will definitely be talking about off-label, off-protocol, future direction approaches. Elastic plasmacytoid dendritic cell neoplasm. This is a disease with worldwide incidence, really unknown until the last decade, and a fairly aggressive hematologic malignancy, with median overall survival generally less than 2 years in almost all series. This unmet medical need has now had its home in that it has its own classification name that has been crystallized since 2008 WHO classification. BPDCN in the clinic is a very strange and difficult to diagnose disease. Many of you have may seen a case, but it usually is mixed up and confused for leukemia cutis, so AML with skin lesions, CMML with skin lesions, or even cutaneous T-cell lymphoma or other lymphoma presentations. But make no mistake about it, BPDCN is its own entity. It appears to be a hybrid between leukemia and lymphoma, and it has 4 major compartments. Number 1 is the skin. Almost all patients at some point will have cutaneous involvement, not always at presentation. The concept is that the lymph nodes, CNS system, and bone marrow are also involved. So 4 major compartments for diagnosis and follow-up. Number 2 is that the disease, BPDCN, can go anywhere. So unlike some of our AMLs, which usually tend to be bone marrow and blood with rare extramedullary, this is common for that. And that may be because it expresses CD56. And the hallmark of the disease is difficult. The only thing that's 100% of cases is overexpression of the surface marker CD123, IL-3 receptor alpha, and then you usually will have positivity of CD4 and 56. So that initial triad we thought would be enough So we told people, think 1, 2, 3, 4, 5, 6. I think it's a good start. But now we know we need to differentiate BPDCN from AML leukemia cutis and other entities. And so 3 more markers I would encourage you to add to your panel. TCL1, which you will not see positive in AML, is positive in this disease almost 100% of the time. TCF4, and then CD303. If you have these 5 or 6 markers, you'll have 100% sensitivity and specificity for this rare disease. The molecular mutations are usually centered around the ones you already know from MDS, CMML, and AML, and they are the usual TET2, ASXL1, RAS. One interesting mutation is the ZRSR2 in BPDCN, which is a splicing mutation you may recognize from MDS and CMML. That's common in this disease, and of interest, it's on the X chromosome, as BPDCN is 5-to-1 male predominant. So usually older patients, 70 is the median diagnosis, usually male, 5-to-1, and outcomes are 1.5 to 2 years historically with chemo regimens. The first-in-class agent, which I helped to lead and pioneer, tagraxofusp, or TAG, by Stemline Menarini, is the first-in-class and only US or EMA FDA or EMA approved agent for all of BPDCN and represents the start of a new era with CD123 targeted therapy. So as we think about BPDCN together, this rare disease is now starting to come to the mainstream of hematology. You will start to see it on board certifications, recertifications in the clinic now that we have the TAG approved drug. After all, BPDCN is a visual disease, and so for the first time in my life, I have to talk to dermatologists every day. I never thought I would do that as a hematologist, but they have been key colleagues in the diagnosis and management of this awful disease. Seen here are pictures from myself and colleagues all over the world. BPDCN usually presents as maculopapular, purplish, dark red lesions, but they can develop into really, really nasty plaques and large tumor balls if left untreated, and it does underlie how rapid progression this disease is, and so patients are at risk for TLS, tumor lysis syndrome, upon treatment. So as we think about BPDCN, why is it so rare? Well, first of all, in the US, we really do think it's a rare disease, maybe 500 to 1,000 cases a year, but I will say that APL, other diseases, hairy cell leukemia are as rare, and we have nice treatment programs and recognition there. The nomenclature has changed every single time there's a WHO revision, every single time. Here's a chart that shows you that, and they're really different names from each other. Finally, in 2008, this BPDCN finally came as a crystallized name, hasn't changed since. It used to be under AML, then its own unique myeloid neoplasm, and then kind of amazingly and unexpectedly, it changed categories again in the latest 2022 to dendritic cell and histiocytic neoplasms under the heading of PDC neoplasms to differentiate the mature PDC, which can be more of an entity in CMML or AML, and then of course the BPDCN entity that we'll be talking about here. So that's interesting. The name at least has stayed the same, but categories change. That confuses the diagnosis over time. As I mentioned to you, unfortunately, awful dismal outcomes. Some of the series shown here on the left. Usually a CR rate of 40 to 50%. It's usually like an AML type of a CR rate, blasts below 5%, count recovery. It's only about half the patients with usual 7-3 AML or usual CHOP lymphoma or ALL therapies, and then super high death rates. Most patients are older, frail, comorbidities, other malignancies, and then the overall survival, as I mentioned. So really, as I got into this field, when people say urgent unmet medical need, we really had that here. I started to do with our team at MD Anderson a search for targets. There were none. There were no targets for BPDCN. One obvious one that came to our attention was the surface marker CD123, seen in 100% of BPDCN cells. That's the IL-3 receptor alpha, as we mentioned. And one of my colleagues, Dr. Art Frankel, in the 90s and 2000s, was working on a molecule that would be able to target that. We also have second-generation CD123 agents we'll discuss here, including IMGN632, pivekimab, and then CAR T cells. So let's think about IL-3 receptor alpha CD123. Why is that so important? And it's really the crux of the issue for this talk. That's because CD123 is overexpressed in the majority of leukemia stem cells. So most of our AML patients, I would say 75 to 90% will have CD123. It's the transmembrane alpha chain of the IL-3 receptor. It's expressed at high levels not only on PDCs, plasmacytoid dendritic cells, but also monos, basos, eos. And it is kind of this important factor that you have the binding of IL-3, then you have the heterodimerization with the common beta subunit on this IL-3 receptor, and then this leads to the usual proliferation, cell differentiation, cell signaling for these important white cell subsets. 100% of patients with BPDCN, as I mentioned, but also the vast majority of patients with myelofibrosis, CMML, AML, even lymphoid diseases, Hodgkin's lymphoma, then you'll have hairy cell leukemia, mastocytosis. So quite a wide array will have this CD123 expression, obviously making it an attractive target outside of BPDCN. So in the BPDCN story, now this is about 10 years old, we started to take this Frankel agent, which is in fact the tagraxofusp, now known as SL401, really one of the great stories in our rare disease kind of category. So this is a truncated diphtheria toxin payload, modified, fused to a human recombinant IL-3, given as an IV drug, 15 minutes with ample pre-medications, usually given as 5 days. And with this agent, with really just one cycle in this pilot study published in Blood 10 years ago, we showed that the vast majority of patients with BPDCN, this is a large study of 11 patients at that time, almost all of them achieved a remission, almost all were CRs, several of which were quite durable. In this pilot study, with accompanying editorial by Fitzgerald from the NIH, heralded the possible start of a new era in this ultra-rare disease. And so with the STEMline team, we took these results with the pilot study and launched the first ever multi-center, multi-cycle prospective phase 1/2 trial, building on the pilot results. And it was a phenomenal experience. Led by our team at MD Anderson, my mentors, Dr. Marina Konopleva, Professor Hagop Katarjian, the chair, we were able to take this drug with the STEMline team to FDA approval. An extremely large trial of patients with this rare disease, including 29 frontline patients. We demonstrated a frontline overall response rate of 90%, 90, with 72% complete remissions, and a respectable 67-68% of the relapse refractory setting. 5 days dosing, the cycles were 21 to 28 days, and this ultimately led to FDA approval December of 2018, marking not only the first FDA-approved drug for BPDCN, but also the first and only FDA-approved drug targeting CD123. And as with any new drug, we experienced some things together for the first time. One was the absolute rapid clearance of these extensive skin lesions. We've never seen anything like this before in the clinic. This was one of my patients, 71-year-old woman with extensive disease in all 3 of the major compartments, skin, lymph node, bone marrow. After just 1 cycle, she had complete resolution and durability of the resolution of the skin lesions, completely all gone. Sometimes patients will have pruritic lesions or maybe not feeling well to go outside to socialize with these skin lesions, and so the disappearance of them can add to the quality of life of the patient. This older patient, who was a bit frail at presentation, improved her performance status and was able to go to an allogeneic stem cell transplant, another amazing benefit of the tagraxofusp program. Well, furthermore, into the EMA, the tagraxofusp agent was put forward, and there the EU did ultimately approve the agent January of 2021 in adults in the frontline setting. They did acknowledge the data set from the previous slide, also correctly noting the capillary leak syndrome, which the FDA also noted. So FDA noticed the capillary leak syndrome as we expected. That's a so-called black box warning. 18 to 20% of patients will get it, usually restricted almost always to the first cycle, but it can be potentially life-threatening. And we did have 1 or 2 deaths early on with this, and then after we modified based on albumin and other parameters, it's a quite manageable and expected side effect and can occur at low grades as well. So in this data set, the EMA also gave the approval in the frontline setting for adults. Interestingly, I forgot to mention, the FDA actually gave broad approval ages 2 and older, so it can be used in the pediatric setting in the United States as well. In terms of safety and tolerability of this new agent, I always try to say new agents bring new toxicities, but with experience, education, mitigation, you can address that. And my great colleague and our friend who just introduced me, Dr. Mansour Al-Fayez, was one of the great collaborators with me over the last 10 years, and he wrote a beautiful paper that everyone should look at, in which this algorithm is well cited in our field. what we realized is we can save lives. We can prevent death by a very easy system, which is shown here. Capillary leak syndrome, the accumulation of life-threatening fluid in the heart and lungs, can be kind of addressed by looking at these. First of all, before giving TAG, you have to know the albumin. There should be a certain parameter, 3.2 or above. During the administration of the TAG on the dosing days, watch the albumin and daily weight daily. If the albumin is too low or the weight is too high, you must hold the drug. You can replace with albumin and Lasix, and then monitor again. You have basically a 10-day window for the 5 doses. If the patient is getting super ill with the capillary leak syndrome, we found that high-dose steroids given rapidly and several doses can literally prevent the patient from death, ICU. If the patient does go to ICU, vasopressors early on are preferred as you're trying to watch for volume with the high-dose steroids. We have many patients who were able to either be salvaged from the ICU or prevented from there, re-challenged with the drug, and did very well, because this is usually a first dose phenomenon and exposure. I do spend a lot of time in the clinic talking to the patient about the capillary leak syndrome, so they're aware, family members, pharmacists, nurses, and we have had really no problems, major problems with this post-approval. And in Europe, I would say my colleagues in Europe do an even better job in terms of education, prevention, monitoring. So I think the center of care, the physician team, pharmacists, nurses, it's fairly well managed in the real world setting. One such example of this capillary leak was a young patient of mine, 30-year-old male, who came to get TAG-based therapy for newly diagnosed BPDCN, and he did experience capillary leak in the first cycle. In his case, it was a bit unique, fairly fit young man, kind of massive fluid gain in the first cycle. We did cardiac imaging, which was really quite a bit of fluid around his heart, consulted cardiology. Interestingly, they did a cardiac MRI, which we have not done previously in our patients, which showed such massive fluid infiltration in this young man that the radiologist called me and said, "Hey, I think this patient has cardiac amyloidosis as a second diagnosis." Well, that's weird. Why would he have that? Diuresed the patient. Within less than the first cycle, we re-imaged and everything was completely gone. It just ended up being a fluid presentation in this young man. He never went to the ICU, steroids, diuresis. He got re-challenged with multiple cycles of TAG, went to an allotransplant. He's alive and well now, 3.5 years after this incident. The suggestion is capillary leak syndrome can happen. There are techniques and tools to reverse it. Patients can be re-challenged and do well later on. So it's part of knowing about this new drug. Well, what about the long-term benefits of Tiraxplus? I'm really pleased to show you this hot off the presses, our latest paper in JCO. Really proud to have collaborated with the Stemline Menarini team to bring this, which is to show not only the 3 stages in the New England Journal paper, but a 4th stage. So a total of 89 patients treated, the majority of which 69 were frontline patients. And you can see some of the data on the slide here. Essentially, out of these frontline, 65 patients received the 12 microgram target dose. And out of those 65 patients, the majority of which, 92%, as you'd expect, had skin involvement. Overall, we found no new safety signals with the 3-year median follow-up and a very respectable CR rate and overall survival. I think also the key with giving the TAG agent is people do not lose the hair, very few neutropenic fever admissions, very well-tolerated drug. In the first cycle, you watch for transaminitis, so AST, ALT, and 50% elevation, thrombocytopenia, transient, the capillary leak, as we talked about. Usually the subsequent cycles are extraordinarily well-tolerated. Many patients are able to bridge to transplant despite older age. And then the median overall survival probability at 12 months, very, very nice at 55, and then up to 24 months at 40%. Here's the Kaplan-Meier curve. Again, median follow-up of 3 years, a very nice tail to the curve. And we have many of these patients still active in the clinic in the long-term follow-up setting. And so the summary, I think, for this first part then, for the Tiraxplus TAG SL401, is that in a disease of rarely understood, very dismal outcomes, older patients, you have the first-in-class targeted therapy, CD123, diphtheria toxin-based, super high response rates, particularly in the frontline setting, with the majority being complete remissions, high rate to bridging to transplant, capillary leak syndrome, as we discussed, you must be aware. And then amazingly, this drug is now in trials in combination monotherapy throughout myeloid and lymphoid malignancies, now even including into the ALL space. So beyond the Tagrax agent, I'm happy to tell you that other sponsors are working on the CD123 space, so we have a brand new field. The second generation is known as IMGN 632 by the Immunogen company, and this is a novel CD123 targeting platform known as an ADC. In this experience, which I presented publicly at the ASH meeting several years ago, first concentrating on relapsed refractory patients, 29 patients, median age of 72, mostly male as we would expect from the historical, mostly skin involvement, but they're a heavily pretreated group of patients for this first data set. You can see here primary refractory over half, 2 or more therapies in half, prior intensive chemotherapy in 50%, prior TAG in almost 50%, prior transplant in almost a quarter. The IMGN 632, now known as pivekimab sunirine, is given as an IV Q3 weeks drug, can be given as outpatient starting in the first cycle. Overall, in these first 29 patients, no capillary leak syndrome reported, no drug-related discontinuations, and some rare AEs as shown here, including thrombocytopenia, neutropenia, hyperglycemia, a couple of cases of liver-related AEs. So generally well-tolerated agent, overall response rate. Now this is in relapse refractory, heavily pretreated. So a respectable 29 to 30% in this setting, including with prior Tagrax plus treated patients, no major safety signals as I mentioned. And so this program has now moved into the frontline setting, monotherapy, BPDCN newly diagnosed, and we await those data sets. Other forms of targeting CD123 team are through CAR T cells. Obviously, we're very excited in the lymphoid space, CD19 in particular with multiple approvals. Not quite the excitement yet at BPDCN and AML, but we're trying. So the first CD123s are there. I think the concept here is a good one, that you have a surface marker that's accessible to therapeutic intervention, but there has to be a therapeutic gradient between the normal hematopoietic stem cell and the malignant stem cell. Preclinical studies have been conducted by our colleagues around the world, France, MD Anderson, Dana-Farber, and others. I think the key is that this field is still super early. The Selectus trial that we started, the first patient actually experienced death, and we published that case report as a clinical correlation autopsy to the clinic. It was an older gentleman, 78-year-old man, so we closed that arm, but the AML is doing well and is actively enrolling. The City of Hope product showed 2 patients, I think initially were treated with BPDCN, some early responses, again, in older patients. And so that trial, we await the final results of that. So there are colleagues who are working on CD123 CAR T. Of course, you know about CD123 bispecifics. Let's see if we can apply some of those into the BPDCN field and not just in AML. Moving beyond CD123, we have the BCL2 program. Everyone is very familiar with that from all the other diseases. But did you know that in our BPDCN, it actually expresses super high levels of the BCL2 and appears to actually be dependent on this protein, maybe even more so than AML. In a recent, actually not so recent, 5-6 years ago, paper published by our groups, my group at MD Anderson, Dr. Lane, and Dana-Farber group, we showed that BPDCN is even more expressing and dependent on BCL2 than even AML. And in this program, preclinical to clinical studies, we gave venetoclax preclinical models and then into 2 patients who were multiply relapsed refractory older patients with transient but powerful responses as a monotherapy published in Cancer Discovery, but the suggestion being that venetoclax has activity in BPDCN, but possibly, as we've seen in other programs, in combination may be its best approach. And so building on that, at our MD Anderson Center, we did give the Cantargia hyper-CVAD regimen with venetoclax to 3 patients with BPDCN, borrowing from an ALL paradigm. And all 3 patients, including 2 relapsed refractory, had very nice, beautiful CRs. All 3 were able to go to an allo transplant and did very well. And so this combination approach of chemotherapy with ven, which is now becoming popularized throughout the malignancies, is now crystallized in our ongoing MD Anderson-based clinical trial with the comprehensive program of CD123 with TAG, hyper-CVAD, and VEN for younger fit patients. Mini CVD VEN we'll use in the older unfit patients. In the real world, particularly across Europe and Asia, many people do not yet have access to the 123 drugs, or some may not qualify for them. So in this real world setting, very important to me, especially if you call me for a referral, we must think about the global incidence of BPDCN. It's everywhere. Ven-HMA combinations, which now have been popularized in AML. We've already been testing in BPDCN for a number of years. We have published data that shows that this program is effective, particularly in the older, unfit patients. It can lead to skin resolution and bone marrow reduction of blasts. Every once in a while, we have had patients who can go to stem cell transplant who were unfit, unwell, and then improved the PS. We also combined with the Mayo Clinic in Rochester, Dr. Naseema Gungat, Dr. Teferian team to publish a series of 10 patients between our two centers. Again, the whole goal was real-world patients, median age of 70. All of them had comorbidities, some renal dysfunction, concomitant malignancies, and again, either aza-ven or decitabine-ven proved to be some form of an active treatment for these patients who really cannot tolerate chemotherapy or 123 agent, and even 2 of those patients were able to ultimately bridge to allotransplant. And so we've crystallized that approach now in a clinical trial, which is to give it as a triplet, so SL401 tag, aza-ven. We built up from single agent to doublet and now triplet, as I've sort of shown you the data here. This is open in 3 centers in the US, Dana-Farber, MD Anderson, and City of Hope. I really think this is a very nice approach, particularly for the older unfit patient or even the younger patient, to give this triplet in a clinical trial setting. What about chemotherapy? We're trying to think about global burden of BPDCN. So CD123 story is fine. We've talked about that. Venetoclax is fine. Sometimes not everybody has access to these agents. Well, one good part is from the chemotherapy era, when I look back, I found 2 essential components that I think are worth keeping in the modern era for BPDCN. Number 1 is that of CSF burden of this disease. This was a signal that was missed with the excitement of the targeted therapy era. Dr. Kantarji and I went back and looked at our series of 100 patients at that time, and to our surprise, we found that 22% of our patients had a CSF positive at some point in their BPDCN course, half of them frontline, so not all at the time of relapse. These patients were usually occult asymptomatic, meaning they were picked up on a routine lumbar puncture. And the CSF positivity cohort appeared to trend with significant p-values for some subsets, more anemic patients, more TET2 mutations, higher rate of bone marrow involvement, obviously maybe shorthand for higher disease burden in general. The action plan from this has been game-changing for our BPDCN field, and all groups around the world have adopted our concept, which is we've started to do IT chemotherapy, lumbar punctures. I do 2 per cycle, alternating IT or CIT methotrexate, exactly as I do in the Kantarji hyper-CVAD ALL paradigm. Usually I try to aim for 8 lumbar punctures, that's right, 2 for the first 4 cycles. With this, we've obviously been able to catch CNS positivity quickly, and we've been able to treat it as well. So I recommend that as a big-time practice-changing maneuver. The second part of the chemotherapy era is out of all the regimens, AML, CHOP lymphoma, ALL, the intense ALL regimen in the young fit patient and then the older ALL for the older patients appear to be the most active chemo-based regimens for BPDCN, so I think there's still a role for that. There's many reasons for that, and several groups around the world have published on that. And it looks like each component of the ALL regimen has some activity. Steroids, BPDCN is a very steroid-sensitive disease. Vinca alkaloids, obviously CNS penetration of the chemo systemically, the IT chemo. A lot of patients with BPDCN are TDT positive, etc. So it does look to be a scientific rationale for ALL-based therapy in BPDCN. To that end, we looked at our own series using the hyper-CVAD regimen in BPDCN, realizing that it's somewhat of a difficult regimen in some locales around the world because you do have to monitor for infection, sepsis, transfusions. We did see an 80% response rate, CR rate, for patients getting this regimen with a median overall survival approximately double the historical, 1 to 1.5 years. Again, I still think the key basically from this is some type of CNS penetration of your approach. So again, what we're doing is regardless of what you're doing, even if I'm doing CD123 monotherapy, I'm recommending lumbar punctures with IT chemo to make sure you're penetrating and crossing into the blood-brain barrier. Allotransplant, of course, as in many of these aggressive myeloid malignancies, remains a curative option. The problem is most of our patients can't go. We all know that. Most of these patients are older, sick, frail. But if you do have the young BPDCN patient, in our series, the ones who went to transplant, the median age is 39, so exactly half the real-world expectation. As you might imagine, at our center, this is 17 patients, very nice tail to the curve, and I do have some long-time survivors now out of stem cell transplant 5 years and beyond. That's a very satisfying approach. So obviously, let me say out loud that allo transplant in CR1 remains a very curative option. And so as we think about BPDCN in the modern era, we know about chemotherapy, so obviously that's still important. I recommend an ALL-based approach. If you can add in the venetoclax, I think that maximizes your response rates. If you have access to 123 therapy, the TAG agent has proven to have a high response rate. The clinical trial, the IMGN, is available in the US and Europe. Of course, if you have an older, unfit patient, HMA-VEN, as I showed you, all patients, I believe, should now get CNS-directed therapy. And then if you have a fit young patient, add in allo transplant in CR1. I do think that the future, if you'll allow me to say, should be that of combination therapy. As we've seen in AML and multiple myeloma, let's move to frontline combination therapy, because when this disease relapses, the outcomes are extraordinarily poor, highly resistant, difficult disease. So can we do CD123 BCL2 chemo for the young fit patients, CD123 hypomethylator, BCL2 for the older unfit patients, CNS prophylaxis for all, and maybe we can eliminate needing stem cell transplant and relapse. Obviously, for the future, I'd like to see more teams exploring and investigating other ways to target 123, novel combinations, and of course, always want to search for brand new targets out there. With the remaining few seconds, I just wanted to show you a few things we're working on for the future. I'd love any of your collaboration on any of these projects. Number one is that of PCHM, prior concomitant hematologic malignancies. This is extraordinarily common in BPDCN. It's become a huge problem, guys, and so we need to really work on that together. I think the key is that 20 to 30% of our patients will have one of these, usually MDS CMML. Sometimes it's in the background, sometimes it's active, but you can also see multiple myeloma, we've seen TALL, we've seen MPNs. There is some commonality in the mutations. Almost all of my BPDCN patients will have TET2. That's one of the big findings. But we do need to work on this together. And how do we do response rates? You have a patient who gets a remission from the BPDCN, but the PCHM is still there. The platelets are not quite 100. When we look at other aspects of BPDCN, our colleagues from France have really tried to think about the genetic and phenotypic heterogeneity. So trying to identify at the level of the PDC, so single-cell sequencing, RNA sequencing, transcriptomics, are there other targets and other markers that we might be able to hit? Are there different types of PDCs involved? I think this is very worthy work and may help us identify new approaches to our rare disease. In terms of genomics, I mentioned to you this ZRSR2. This is work by my colleague, Dr. Lane at Dana-Farber, where we were included as well, which really showed that this splicing mutation, which is on the X chromosome, is aberrant in BPDCN, and that may lead to an impaired PDC program. But the implication is that it's a male-predominant disease. This is an X chromosome aberration. Is there a connection there? So I'd like to see more work on the genomics of BPDCN at a worldwide effort. I mentioned to you TET2, our group has interest in that. This is by far the most common mutation or variant in BPDCN. I think that could be a board question at some point. Even in patients with quote-unquote skin-only disease, you do the bone marrow, it's negative, but if you send the gene panel, many of these patients will have TET2, possibly representing a chip type of presentation, or maybe it's part of the malignant driving clone. We looked at the TET2 in a little bit more detail. So we took TET2 mutated AML compared to TET2 BPDCN, and we found that the eotaxin and RANTES chemokines are higher in BPDCN, suggesting BPDCN is a more cytokine-rich, sort of a hot disease compared to AML. We then looked at TET2 mutations in more detail in BPDCN and found that certain type matters. Can you believe it? So type of TET2 matters. And in this small paper that we published in Blood Advances, we found worse overall survival in BPDCN in the nonsense frame shift splice site, so the major TET2 mutations. Again, I think it's important that TET2 is coming up a lot. So CHIP, now I'm telling you BPDCN, CNS positive, I showed you that slide, those were TET2. You have some ability of HMAs working in this context, so there is something there that we must explore together. Finally, there is a new entity, overlap entity between BPDCN and AML known as PDC-AML. Yes, that's right, I didn't make that up. All these things sound like I made them up, but it's real. This paper from Ross Levine at Sloan Kettering, right at the beginning of the pandemic, beautiful paper. that showed that maybe 3 to 5% of AMLs fit this category. So they're obviously CD34 positive AML, but they also will have the 123, 456. So kind of a PDC population, maybe 2% or more. But amazingly, not TET2, but they found that the majority of these patients are RUNX1 mutated. In pure BPDCN, we see RUNX1 almost never. I would say less than 1%. But in this entity, it's almost all these patients. And that appears to be because RUNX1 is apparently part of the PDC transcription platform. Interestingly, in this PDC-AML entity, they found more skin lesions, worse overall survival. Preclinical models suggested that the tag agent works very well in eliminating the PDCs and decreasing leukemic burden in this subset. And as I mentioned to you, we have ongoing trials in the US with the Esoprol and Veneza in both AML and BPDCN, so we'll wait to see those results. And so I was asked to write the editorial for that exact paper, and I basically wrote the question, targeting the PDC, is it easy as CD123? And I think, as you can see here, the answer is not quite yet, but it's definitely the start. And so I think that BPDCN is a very complex, heterogeneous, deadly disease. The tagraxofusp and CD123 story has opened the door to a brand new era of improved patient outcomes. And I'd like to see us build on that with combination therapy, the elimination of the stem cell transplant, elimination of MRD, and really going for the cure for these patients. To that end, we started the North American BPDCN Consortium. I'm very proud to share this with you, published in Blood a few months ago. And in this, we took colleagues from US, Canada, Mexico, across North America, but really multidisciplinary, pediatrics, dermatology, dermpath, hemepath, transplant, med-onc, and we all had a series of expert-level meetings asking and answering the top questions in the BPDCN field, many of which I shared with you here. And I hope that this leads to a new era of rare disease clinical trials, discoveries, and collaborations that can change this field forever. I think as we close here that the importance of talks like this, social media, internet is so important now after 3 years of a global pandemic, more important than ever. I would encourage you to reach out to me on Twitter, #BPDCN, @DrPem. You can follow me, MD Anderson, Dr. Al-Fayez, many of our colleagues on this call. We can safely and nicely communicate the rare disease findings and cases across the world to better help these patients. And so with that, I'd like to thank all of my colleagues at MD Anderson, particularly Professor Kantarjian, Professor Konopleva, my colleagues around the world, and my grant support agencies. And Dr. Mansour, I'd like to turn the floor back to you. Thank you so much for this amazing opportunity to connect with colleagues from Saudi Arabia.
All right. Thank you very much, Dr. Bamaraju, for being with us today in your busy day. We'll take just a couple of questions as we are tight on time. Maybe we can take one or two.
Thank you very much for the excellent and informative talk. Can you please comment on targeting CD123 in AML? As far as I know, it's not specific on the leukemic stem cells in AML. It's also expressed in the normal hematopoietic stem cells. Can you elaborate on that, please?
Thank you for this important question. The question is about CD123 expression and targeting in AML, extremely important as that's more common than the BPDCN entity. So you're correct on all points. CD123 appears to be expressed. It's a wide variety in the literature. You'll see it anywhere from like 50% to 90%. And that's because of 3 reasons. One is because we found out there's 8 to 10 different assays in the United States for CD123. So they're not all consistent. Number 2, you can check CD123 in the IHC or the flow. One might be positive, one might be negative. And then number 3, there is some sampling where you can be negative and then test it again and it's actually positive. So I would say the vast majority of AML have it. The targeting has been fraught with difficulty thus far. The first attempts were with the bispecific, so you know those agents possibly, so that's flotetuzumab and some of these other agents. A nice approach, CD123x3, but did not make it to FDA approval yet. Then a second approach was CAR-T. That's the Selectus allogeneic off-the-shelf CD123. That's still in phase 1. That's ongoing. We did show those data publicly at the ASH meeting this past one a few months ago. And that one we showed that there's now safety and a dose at the dose level 2, and that study is ongoing. And then finally, the IMGN program. That's something that has proceeded on. As monotherapy, modest results with AML, but as combination, IMGN Ven-Aza, that has been very promising. That's moving nicely in clinical trials. The SL401 itself, again, modest activity as a single agent in AML, but some nice activity with the triplet of SL401 Ven-Aza, and that's moving in clinical trials. So I think your question is excellent. I would say basically CD123 very commonly overexpressed in AML. Number 2 should be a good target, but number 3, there's been quite a bit of toxicity early on. So the field has had to modulate that, and now that it's moved into combination and triplets, we await to see those data, but I'm very positive about it, that it can be a game changer in AML once we get the toxicity down and we show that the efficacy is better than single agent.
Excellent. Thank you very much, Dr. Bemraju. Any other questions? All right. I'll just ask mine. Notice when you did the triplet, you actually use HMA, Ven plus Tagro. Why would you not do mini CVD Ven Tagro?
Ooh, nice. So Dr. Mansour's question is very nice. So the answer is we are doing both. So you're right. So the first approach was TAG, Ven-Aza. So that's ongoing clinical trials for AML, BPDCN, as we mentioned. Very nice preliminary data so far. But as you mentioned, since we believe chemo is also active, we have the second trial for TAG, SL401, so TAG, Ven, hyper-CVAD, or mini CVD. But one thing I do in the off-protocol setting sometimes is I do use all of these. So sometimes you'll give TAG, Ven, and then you can alternate it with mini CVD Ven. So I would say that your point is a good one, that you can use really all 4 of these classes in the real-world setting as alternating agents. But for the clinical trials, we do have both approaches, as you asked.
Excellent. Thank you very much, Dr. Bemraju, for being with us today.
Thank you.
Hopefully we'll see you next time in person.
Absolutely. Thank you for your kindness, generosity, and collegiality, Mansour, and to all the colleagues in Saudi. It's an honor actually to be here with you. Have a wonderful meeting.
We're going to start the next final session of the conference, and the first talk of this session will be by Annalisa Ruggeri. She's a graduate of the University of Messina, Italy, and she did her fellowship in bone marrow transplant in Paris, St. Louis Hospital, and she then went on to be the working at the Tripiato in Biotica Hospital in Milan. She's the chair of the Cellular Therapy and Immunobiology Working Party of the BMT. And she'll be talking to us today about cord blood transplantation now and next.
Good afternoon, ladies and gentlemen. It's my great honor. Good afternoon, ladies and gentlemen. Good afternoon. Good afternoon, ladies and gentlemen. It's my great honor to talk with you about now next of cord blood transplantation during the prestigious meeting of the Saudi Society of Blood and Marrow Transplantation. I am Annalisa Ruggeri from the San Raffaele Scientific Institute in Milano, and I am the actual chair of the Cellular Therapy and Immunobiology Working Party and the vice president of the registry. And I have no disclosure related to this talk. So why cord blood transplantation is such unique, important stem cell source? This is mainly related to the typical properties of cord blood cell, which are mainly associated with the longer telomeres and the higher number of immature and naive T cell and T regulatory cell, and also the possibility of tolerate better HLA mismatch due to also to the maternal microcardialism present at birth. The donor are immediate available, and we have seen how this was extremely important during the recent pandemic that we all faced, and there are no risk for the donor. Today in the public cord blood bank there is a huge inventory of units available, well stored, with high quality of cell, and the use of cord allow to expand the access of allogeneic transplantation also for ethnic minorities. Several studies over the last 35 years have demonstrated how rigorous selection of units allow to improve the results. However, the delayed engraftment remain the main limitation of this procedure. Here is a picture of the trend and activities in Europe as reported by the BMT for cord blood transplantation and double identical transplant. And we can clearly see how after the early 2000, with the feasibility of post-transplant cyclophosphamide in the haploidentical setting, the number of cord are decreasing with a constant increase of the number of haploidentical transplant recipient. And this is related to the different type of disease, and cord remain used in approximately 25% of the pediatric transplantation reported in the registry. The same scenario could be considered also for the United States, in which the number of haplo are increasing and the number of cord remain across 18-20% for patients younger than 18 years, while for the older patients the activity, especially for those over 65 years of age, is decreasing so far. The situation is different in Japan, in which, due to the specific HLA characteristics of the population, the number of cord remain still considered as an attractive stem cell source, with a remarkable increase since the last year over the number of unrelated donor transplants. So haplo is increasing also in Japan, but the number of unrelated are most performed using cord blood transplantation. Which are the main factors associated with transplant outcomes? One is the number of cell dose. The total nucleated cell dose is extremely important and is associated with outcomes, and we know very well how the threshold of 3 per 10 to the 7 per kilo of CD34 is associated with reduced risk of graft failure and better engraftment. Also, the number of CD34 is of importance, and while the criteria for thawing and CD34 count are not well standardized across the centers, there is a threshold of 1.5 per 10 to the 5th per kilo of CD34, which is considered a safe threshold for outcomes. And several investigators, especially in the United States, in the early 2000s, developed the strategy of the double cord blood transplantation in order to overcome the cell dose limitation. These were two that were with the idea of adding a second unit in order to reach the number of cells needed. However, there was no clear advantage of this approach in two prospective trials, one in the US and one run in France, clearly showing that for children and young adults, using a myeloablative regimen, when a single unit with an adequate cell dose was available, there was no clear advantage of adding a second one. And also, of course, given the increased risk of cost adding a second unit, this has been one of the most important limitations at the widespread of this approach. And what about the HLA typing? So historically, cord blood transplantation, cord blood units were selected at antigen level for class 1 and allelic level for class 2, but more recently, we, in collaboration with the CI-BMTR and the BMT, we clearly demonstrate how there is an advantage of performing high-resolution HLA typing in terms of reduction of non-relapse mortality and better progression-free and overall survival. This has been demonstrated in also including the HLA-C in the algorithm for the donor selection. So again, using the C and avoiding more than 2 HLA mismatch is one of the most important factors associated with the outcomes. And again, preferring the mismatch in the class 1 rather than class 2. And also with that, with this study, we were able to clearly demonstrate how, again, the number of cell dose with a threshold of more than 3 per 10 to the 7 per kilo remain the most important factor. There is no advantage in increasing further, even over 5, the number of cells. However, it is important to not decrease and to not provide fewer cells in this setting. So all these studies allowed us to provide criteria for the selection of the cord blood unit, also shared by other societies and the CI-BMTR. So the number of cells that should be considered is the TNC count with more than 2.5 and 3 per 10 to the 7 per kilo, and CD34 between 1 and 1.5 per 10 to the 5th per kilo. Considering the high resolution typing for HLA, including HLA-C, and avoiding more than 2 HLA mismatch, and also considering the mismatch in class 1 always before choosing a unit with HLA mismatch. And also performing the screening, the systematic screening for anti-HLA antibodies, avoiding units in which the recipient has specific donor-specific antibodies, and consider also if in case of different units available, also the biocompatibility and avoiding red blood cell repeated unit. So all these studies allowed to clearly demonstrate an improvement of transplantation over time, which has been also showed for cord, and this is a recent study from colleagues from the Acute Leukemia Working Party of BMT, clearly showing how in the more recent epoch there is a clear reduction in mortality and a better overall survival for patients receiving cord blood transplantation. And these improvements are mainly related to a reduction in non-relapse mortality and in a better disease control with a lower relapse incidence in the more recent year. This is the picture for the European Center, but also colleagues from Japan were able to demonstrate an improvement in non-relapse mortality and overall survival by 30 years in terms of namely reduction in the more recent year and better OS. Other which are the most important factors associated with the amelioration of the results across the time. Of course, the conditioning regimen, the choice of conditioning regimen, better supportive care. But another important point is the GVHD prophylaxis, in which calcineurin inhibitor and MMF are nowadays the most common used combination. However, there are different studies showing also good results with tacrolimus and sirolimus. An important point which has been clearly demonstrated and is the detrimental effect of ATG, namely due to the increased non-relapse mortality associated with this kind of procedure. The use of ATG, which has been historically one of the most important backbone of cord blood transplantation, is associated with low immune reconstitution, higher viral reactivation, and ultimately higher incidence of relapse. So there are some centers who are developing an tailored ATG level before cord blood transplantation in order to prevent the high ATG exposure and ameliorate the T cell recovery over the more recent year. So here we can clearly see how immune reconstitution could be very rapid and fast after cord blood transplantation in the absence of ATG, showing how the number of CD4 cells already at 1 month after transplantation is increasing with a peripheral expansion, a clear peripheral expansion, and also a shift in the compartment of memory cell, central memory and effector memory in the last months after transplantation. And this is despite the administration of other immunosuppressive agents such as calcineurin inhibitor, but again, no exposure of ATG. So these are a very important point, and nowadays the use of ATG is less frequent in this kind of transplantation. Several different studies from single center and registries were performed over the time, comparing cord with other graft source, and overall the main message is the delayed myeloid recovery, the decreased incidence of acute and chronic GVHD, and the higher non-relapse mortality without superimposable relapse incidence. This is a study from the Memorial Sloan Kettering Cancer Center showing children with acute leukemia, and clearly demonstrated an advantage of cord blood transplantation in terms of the composite endpoints of the GRFS, so the graft relapse and free survival, clearly showing the advantage of patients receiving a single unit with very similar outcome to those patients receiving matched sibling graft, while the use of unrelated donor transplant was associated with a higher incidence of chronic GVHD, which is a very life-threatening complication, especially in the pediatric population. In the adult setting, in collaboration with the CI-BMTR and Eurocord, we were able to demonstrate comparable leukemia-free survival in patients with acute leukemia, confirming how cord could be a good alternative when the selection of cord is done with the rigorous criteria for TNC and HLA. And more recently, in the most common competitor of cord, which is Diablo, there were several different registry studies showing comparable results, but again we should consider the limitation of a registry studies, especially having a group of patients receiving ATG also in the haploidentical setting. Importantly, the prospective randomized trial comparing double unrelated cord blood transplantation with HLA haploidentical bone marrow using the reduced intensity conditioning regimen with the total body radiation 2 gray has been were released last year, the results of the BMT CTN 1101 trial. This trial, which was limited by the slow accrual and was then terminated earlier than the fixed time planned, in patients with acute leukemia and lymphomas, demonstrated no difference in terms of the primary endpoint, which was the 2-year progression-free survival. However, longer follow-up showed how the number of the overall survival was lower for double cord blood transplantation recipient, mainly due to a difference in non-relapse mortality, which was 11 versus 18% in cord in haplo versus cord respectively. So again, cord demonstrated a very effective disease control in terms of relapse, but the non-relapse mortality remained higher, and ultimately there was advantage in survival for patients receiving an haplo. So what is the next? We know very well how the advantage and the main limitation of the fixed cell dose is one of the most important factors preventing the spread of use of this strategy. However, it is important to consider that the research were able to demonstrate over 15 years how cord blood cells are a unique source for cellular therapy, and there are several different possibilities of ex vivo expansion of the cord blood graft to improve engraftment and immune reconstitution with a very broad TCR diversity and a rapid NK cell recovery, reducing the infection rate, the days of hospitalization, and the early mortality. And also, several different trials are now available using cord as a platform for cellular therapies, including mesenchymal cell, NK cytotoxic cell, and also chimeric antigen receptor derived from cord, with a great potential for gene therapy and immunotherapy. So I will briefly mention a few studies which are published and demonstrating the feasibility of this platform. One from the colleagues of Montreal, showing the single platform expanded with the UM171 in patients with severe hematological disease, showing how 22 patients were reported in the first study. The engraftment is faster, with a median of 12 days for reaching 100 neutrophil count, and 18 days for more than 500, and also the days of fever and of hospitalization were reduced for patients receiving the expanded unit. And the results of this trial reported a very low incidence of no-relapse mortality, clearly demonstrating how it is possible to abrogate the excess of mortality in case of better engraftment. Another important study, which has been firstly published in the results of the phase 1, 2, and then more recently the phase 3, is the one by colleagues from Duke University and collaborators, and Gamida cell, showing the nicotinamide expanded cord in the setting of the hematopoietic recovery. So this trial was randomized with a single non-expanded unit in the setting of myeloablative conditioning regimen, and there was a clear benefit of the expanded unit in terms of hematopoietic recovery and platelet recovery, and also length of hospitalization across to the rather than the control. So the main factor associated was the high, huge increase of the CD34 cell expansion, with a 130-fold increase in respect of the unmanipulated units. And the recovery of the immune system with the me-too-cell was early and constant across the days of follow-up, finally better, significantly improving also the health-related quality of life. So very recently, on the 17th of April, the FDA provided the early approval for conditional approval for omidubicel for in adult and pediatric patients with hematological malignancies who, after myeloablative conditioning regimen, to reduce the time to neutrophil recovery and the incidence of infection. So this is an important possibility for patients who may need an expanded unit. And I briefly would like to mention the cellular therapy trials with NK cell on behalf of Kati Rezvani and the lab group from the MD Anderson, showing the feasibility of dose escalation phase 1-2 study of cord blood derived CAR engineered NK cell in patients with relapsed refractory B cell malignancies. And after a lymphodepleting regimen with cyclophosphamide and fludarabine, they were able to demonstrate the expansion of CAR-NK off the shelf in the recipient, and also the feasibility of this approach in expressing CAR to redirect the specificity and cytokine to enhance the proliferation and the persistence in vivo. So this was the first in-human clinical trial, which has been demonstrated feasible with clinical response in 8 of 11 patients, and was published in the New England Journal of Medicine in 2021. So in conclusion, ex vivo expansion of cord blood graft is feasible and promising, and associated with a reduced time to engraftment, namely neutrophil and platelets, and TCR diversity and a rapid NK cell recovery. Of course, cord blood expansion add extra cost to the transplantation, and the impact on overall survival in comparison with other type of donor cell should be demonstrated. And the approach of the use, the possibility of having the off-the-shelf product should be warranted in order to let this opportunity available for all patients in need. And it remains a unique platform for cellular therapies, actually under investigation in a clinical trial. And with that I conclude, thanking all of you for your attention, and all the colleagues and the collaborators from the different centers. And please feel free to email me if you have questions or other detail that you want to discuss. Thank you, and enjoy the rest of the meeting.
I'd like to thank Dr. Annalisa Ruggeri for her presentation. As this is a pre-recorded session, there will be no questions, and I'll hand the microphone to my colleague and friend, Dr. Musa Jamlet, to introduce the next speaker. This is the final presentation of the conference.
Thank you, Dr. Ihab. Assalamu alaikum and good afternoon, everyone. It's my pleasure to welcome our last speaker for the day, who needs no introduction, Dr. Ahmed Sareda, lymphoma expert, world-renowned.
I think that this is the one.
Currently a senior consultant and the head of her hematology division at Barcelona Hospital. And she is the current president of the EBMT, as you all know, and previously she was chair of the lymphoma working group at the EBMT, as well as a co-chair of the lymphoma working group at the CIBMTR. The talk for the day is going to be cellular therapy in lymphoma. This is where Dr. Sareda is best known for, and we look forward to hearing her talk. Dr. Sareda, you're ready.
So you want to say it?
Yeah. Go ahead.
Okay. So only 1 or 2 seconds, we are just finishing with all these technicalities.
No worries.
Okay, thank you. Perfect. So good afternoon, everybody. Thank you very much for staying here until the end of the day and the end of the meeting, and thank you very much for the kind introduction. So I'll try to be as much on time as possible because we are a little bit late, and I'll try to discuss with you cellular therapy in lymphomas and what I found it was the best of EBMT 2023. So here you have my conflicts of interest, and I think that you have seen this version of this information several times during this meeting. No doubt that the introduction of autologous CD19 CAR T cells has significantly changed the long-term outcome of patients with relapsed refractory large B-cell lymphoma that fail at least 2 prior lines of therapy. We have long-term data on the 3 pivotal trials, and we know that around 35 to 45% of these patients can be cured, and that the results in terms of overall survival of CAR T cells are significantly better to the results of patients treated with the standard of care and included in this famous COLOR1 trial. That's the reason why the landscape in terms of cellular therapy in patients with relapsed refractory diffuse large B-cell lymphoma has significantly changed. We have already seen data coming from the CIBMTR, but as you can see here in this slide, the number of patients being treated with CAR T has also significantly increased in Europe. And here you have the data coming from the EBMT registry with more than or around 5,000 patients being reported, 85% of them with relapsed refractory large B-cell lymphoma. Just because of the excellent results of CAR T in third line or plus, there were 3 prospective clinical trials that were presented at ASH 2021 that tried to understand which was the role of these autologous CD19 CAR T cell constructs in second line for patients with primary refractory disease or early relapse. 2 of these 3 prospective clinical trials were positive, SUMA-7 and TRANSFORM, and here you have some data regarding progression-free survival and response rate in the standard of care arm versus the experimental arm. And that's the reason why both constructs have been approved by both the FDA and the EMA. Axi-cel is already being used, and also liso-cel in US, and Axi-cel is being used also in some European countries. We also have information regarding 2 prospective clinical trials that looked at the potential use of CAR T cells in second line in patients that were transplant ineligible. So here you have some data on the pilot study that was performed in several centers in US. The number of patients included was 61, and it was basically checking the possibility to use liso-cel in this specific population of patients. You can see here excellent response rate with an overall response rate of 80%, a complete remission rate of 54%, and really a very mild toxicity profile as we are used to see when talking about liso-cel. And the other important prospective clinical trial I want to mention is a prospective clinical trial performed by the LISA that was presented as an oral communication at the last ASH meeting. It's the Alicante study that it's a very small phase 2 prospective clinical trial looking at Axi-cel second line in patients that are not candidates for an autologous stem cell transplant. So you can see that with a very short median follow-up, only 10 months, the median progression-free survival is 11 months. It was really an elderly population of patients. Neurological toxicity, as you may imagine, was the most important side effect of the administration of Axi-cel in this specific group of patients, and non-relapse mortality was around 10%. I have to say that there were not so many oral communications regarding CAR T and lymphomas in the last TBMT meeting, and then I want to highlight, apart from oral presentations that I'm going to show you later on, some data coming from some educational sessions that I thought they were really interesting. So we have a lot of information regarding the role of CAR T in patients with relapsed refractory aggressive B-cell lymphomas. It was important to demonstrate that real-world data are similar to the ones that we have seen in pivotal trials, and this is one of the different things that Catherine Thieblemont presented in one of the educational sessions. So here you have data coming from the Descartes registry, that probably is the biggest one in Europe, including more than 600 patients. 550 were treated with CAR T, 200 patients with T-cell, and 350 patients treated with Axi-cel. And here you have some overall survival and progression-free survival curves. So the first important thing is that those patients that made it to CAR T had a significant better overall survival. So this is one thing that we might think it's quite obvious. And results in terms of progression-free survival and duration of response were quite similar to what we can see in pivotal trials, 44% and 57% respectively, with a median follow-up of 6.5 months. We also have data, and she presented data from the UK real-world experience with patients being analyzed centrally in a kind of MDT committee that they have in UK. And here you can see the overall survival for the intention to treat population in the black curve, the non-infused population of patients that has a significantly lower median overall survival, and the infused population of patients that has a median overall survival of 16.2 months and 24 months overall survival of 44.1 months. They established a retrospective comparison between AXI and TISA, as it has been done by other registries and by other authors. And as you can see here, AXI was the winner with a better median progression-free survival, 12 months progression-free survival, and median overall survival. And finally, she also presented some data from the real-world experience of the Spanish lymphoma and stem cell transplantation group. Here, what we did was to compare patients being treated with CAR-T with the standard of care in terms of overall survival and progression-free survival. And as you can see here in this slide, those patients being treated with CAR-T in a similar way that was demonstrated with this propensity score retrospective analysis between patients included in the SCHOLAR-1 and patients in ZUMA-1. In this case, also patients being treated with CAR-T enjoyed a better progression-free survival and overall survival than those patients being treated with the standard of care. Another important thing that we have to take into consideration is how to select the best candidates. And although initially everybody thought that CAR-Ts were going to cure all the patients that were treated with this new treatment strategy, the reality is that this is not exactly the situation. So nowadays we know that tumor burden make a difference, and these are results from a retrospective analysis from the French cooperative group indicating that TMTB and the number of extranodal sites make a difference in terms of progression-free survival. Those patients with more than 2 extranodal sites and patients with high TMTB do significantly worse in terms of progression-free survival. We know that performance status is a very important prognostic factor for the long-term outcome, as well as the values of CRP and LDH, as you can see here in this slide. And interestingly, and this is a retrospective analysis that was presented as an oral communication at the last ASH meeting, also the prior exposure of the patients to bendamustine significantly modifies the possibility to achieve a complete remission rate after CAR T-cell infusion and to enjoy a good progression-free survival. So this is one thing that we may want to take into consideration when thinking about patients that are going to be potential candidates for CAR T-cells later on in their treatment strategy. So when selecting patients for CAR T-cell therapy, we have to take into consideration patient characteristics, so performance status, comorbidities, infections, and viral status. We also take into consideration organ function, so lymphocytes, pulmonary function tests, cardiac functions, liver and renal function test, and also age is included here as a question mark because we know that age limits are more flexible when considering CAR-T than when considering autologous and allogeneic stem cell transplantation. If we talk about disease, tumor burden, looking at LDH, TMTB, and number of extranodal sites, and of course, prior disease history. The other important thing that Catherine mentioned in her presentation was what to do with those patients that relapse after CAR-T, because unfortunately, although CAR-T are curing around 40% of the patients, we have a significant proportion of patients that fail after CAR T-cell therapy. And she was basically mentioned the possibility or the interest of including bispecific monoclonal antibodies in this specific setting. They are an effective option. The LISA group did a retrospective analysis looking at different treatment options of patients relapsing after CAR T, and as you can see here, bispecifics seem to be a better overall response rate than other treatment options. And you know that we have 2 pivotal trials. Here you have some data regarding the glofitamab expansion cohort in terms of response and duration of response, and also data coming from the use of epcoritamab, 2 very effective bispecific monoclonal antibodies that have specifically been tested in this group of patients that failed CAR T. Okay, so what else did we have in the BMT regarding CAR Ts in relapsed refractory large B-cell lymphoma? First of all, I want to play a little bit here the devil's advocate, and I want to reactivate the potential role of autologous stem cell transplant, which probably, or maybe it's going to not to disappear, but to significantly decrease in the near future. So we know that one of the reasons why autologous stem cell transplantation is not effective in patients with early relapse of primary refractory disease is because of the incapacity of salvage treatment strategies to achieve a complete remission or a partial remission. And that was demonstrated in the CORAL trial and in the ORCHARD trial, and also in the 2 positive phase 3 prospective clinical trials that gave the indication to CAR T in this specific setting. So that was an oral presentation at the BMT that looked at the combination of epcoritamab plus rituximab DHAX in patients with relapsed refractory large B-cell lymphoma that were candidates for an autologous stem cell transplant. And the objective here was to try to increase the overall response rate and complete remission rate in patients that were potentially candidates for an autologous stem cell transplantation. So only a small number of patients being included, 29 patients. Some of them went into the autologous stem cell transplantation procedure. Other patients continued with maintenance therapy with epcoritamab. And here you have 66% of the patients that progressed within the first 12 months, and a significant proportion of patients that had primary refractory disease. So as you can see here, the overall response rate was 85% with a complete remission rate of 67%. If we look at those patients that went on being consolidated with an autologous stem cell transplant, 81% of the patients were in a metabolic complete remission, and this efficacy was also consistent in patients with primary refractory disease, with an overall response rate of 82% and a complete remission rate of 59%. So another, I think that important piece of information is what happens to allogeneic stem cell transplantation nowadays in diffuse large B-cell lymphoma in the era of CAR T. As you may remember, allotransplant was the standard of care for those young patients that failed an autologous stem cell transplantation. So there was a retrospective analysis that was presented by Bertram Glass regarding the comparison between allotransplant and CAR T cells in patients with relapsed refractory diffuse large B-cell lymphoma, 3rd line or plus, being included in the registry from January 2016 to May 2021. As you can see in this slide, there were some differential clinical characteristics between both groups of patients. The follow-up was shorter in the CAR T-cell treated group. CAR T-cell patients were older. They were more frequently with active disease at the time of treatment. And as you can see here in this slide, in this comparison between both groups of patients, PFS was quite similar, but non-relapse mortality was higher in the allotransplant group. Relapse incidence was higher in the CAR T-cell treated group, and there was a benefit in terms of overall survival. And in fact, when a propensity score was used with variables at the time of lymphodepleting therapy, overall survival was better in patients being treated with CAR T, and because of a lower, significantly lower non-relapse mortality. So basically the conclusions of this study is that CAR T-cell therapy is associated to a lower non-relapse mortality, but a higher relapse incidence, especially in those patients with high-risk disease. And in principle, if available, CAR T-cells should be used as the standard of care in those patients in 3rd line. Another provocative oral communication at the EBMT is this propensity score comparison between standard of care in patients with relapsed refractory diffuse large B-cell lymphoma versus CAR-T, patients included in ZUMA-1, and versus bispecific monoclonal antibodies, basically patients included in the pivotal trial of epcoritamab. And the authors looked at differences in terms of overall response rate and in terms of overall survival after the treatment. As you can see in this slide, bispecifics compare favorably with the standard of care and had a similar overall response rate and complete remission rate that patients included in ZUMA-1. And if you look at the overall survival curves, overall survival was significantly better for those patients being treated with bispecifics in relation to those patients being treated with chemoimmunotherapy, but with no differences between epcoritamab, in this case, and patients being treated with CAR-T. So I also thought that that presentation was really interesting, basically taking into consideration that bispecifics are going to come quite shortly into the market, and we have problems of accessibility of CAR-T around the world. Another oral communication that was presented at the EBMT was looking at the role of CAR-T in patients with primary and secondary CNS lymphoma. That's a retrospective analysis that included 74 patients. As you know, patients with CNS lymphoma were mostly excluded from pivotal trials, and we don't have a lot of information regarding them. 86% of these patients had secondary CNS lymphoma. More than 60% of the patients had received at least 3 prior lines of therapy, and we have almost 70% of the patients that were treated with refractory or progressive disease. With a short median follow-up, the overall survival at 12 months was 51%, and progression-free survival was 34%. Relapse incidence 60%, and non-relapse mortality was 7%. So I'm going to move to mantle cell lymphoma, and I'm going to present some slides of a debate that was developed within the general meeting of the Lymphoma Working Party between CAR-T cells in mantle cell lymphoma, that was basically supported by Gloria Jacoboni from Barcelona, Spain, and the role of allogeneic stem cell transplantation in mantle cell lymphoma, that was supported by Sascha Dietrich from Germany. And as you know, those patients with mantle cell lymphoma that fail BTK inhibitors really have a very poor prognosis in the long term, and the reality is that until the advent of brexucabtagene, we didn't have really a very good treatment for these patients. And this is only a summary of the characteristics of the pivotal trial that was published in New England Journal of Medicine in 2020, the ZUMA-2 trial that gave the indication to Brexucel both by the FDA and the EMA in patients with relapsed refractory mantle cell lymphoma. The primary endpoint was overall response rate. You can see here the key secondary endpoints. Patients were able to receive different sorts of optional bridging therapy and brexucabtagene at a fixed dose of 2 times 10 to the 6 cells per kilo. So the overall response rate was really astonishingly high, 93%, with 67% of the patients being able to achieve a complete remission. No significant differences in terms of overall response rate, depending on the different subgroups that were analyzed in the subgroup analysis, and no fatalities due to CRS or neurotoxicity. We have data on the long-term follow-up of patients included in ZUMA-2 with this 3 years follow-up that was published in JCO in 2022. You can see that basically really interesting results for those patients that achieve a complete remission, with significantly poor results in those patients that only achieved a partial remission or that did not respond. In the same way that there was a propensity score retrospective analysis between the standard of care and ZUMA-1 in patients with relapsed refractory diffuse large B-cell lymphoma. A similar exercise was performed with patients with mantle cell lymphoma. So there was a comparison between those patients included in ZUMA 2 versus the standard of care coming from patients included in different centers in different European countries. And as you can see here, the 15 months overall survival was significantly favoring those patients that were treated with Brexucell in relation to those patients that were treated with the standard of care at that time. And the other important piece of information I want to mention is the efficacy of Brexucell in real world. And we have data coming from different centers in Europe. We also have real world evidence coming from US. This is the European experience, including 33 patients that were infused from February 2020 to August 2021, with a median follow-up of 10.1 months. The 12 months progression-free survival is 50.8%. And the safety profile, here you can see some differences regarding the percentage of patients developing grade 3 or plus CRS, similar proportion of patients developing neurological events, and this might be related to the different use of TOSI and corticosteroids in real life. So differences between CAR-T and allo, they are depicted here in this slide, and probably if we put pros and cons, of course, CAR-T cells would be the first cellular option for patients with relapsed refractory mantle cell lymphoma as opposed to allogeneic stem cell transplantation, and that was an issue that was already discussed in a consensus and positioning paper that was published, I think, a few years ago from different transplant and cellular therapy societies, EBMT, CIBMTR, and ASTCT. Only one slide regarding follicular lymphoma. So the 3 years follow-up for ZUMA 5 that show really interesting curves in terms of duration of response, time to next treatment, progression-free survival, and overall survival for patients with relapsed refractory follicular lymphoma. And this is the conclusion slide. I think that the conclusions are quite obvious, so everybody would agree that CAR-T cell therapy has significantly changed the treatment landscape of patients with relapsed refractory large B-cell lymphoma, and has also demonstrated to be very effective, and it's already changing the way that we are treating our patients with other B-cell malignancies. There are quite a few or a lot of questions to be answered. Probably a better identification of risk factors that will impact on the outcome, what to do with patients that relapse after CAR-T, if we still have a role in terms of allo or eventually auto-transplant for patients basically with relapsed refractory diffuse large B-cell lymphoma, and we can eventually discuss about mantle cell lymphoma and follicular lymphoma. And of course, we will have additional therapies in this setting. Bispecific monoclonal antibodies probably are the most interesting one that might eventually be competing with CAR-T, at least in some parts of the world and in some centers. So with that, I really want to thank you very much for your attention. I want to thank, let's say, EBMT and all the authors that provided me with, I would say that most of the slides that I have presented here. SS BMT for organizing this meeting and for, let's say, taking care of all the logistics and allowing, let's say, to give you the best of EBMT over the last few years. And I cannot forget the dinner yesterday. These are pictures given to me by Sebastian, because I am super bad making pictures with the iPhone. We had a wonderful dinner yesterday with wonderful views and with this wonderful camel bone marrow, which it was for me the first time, and I really enjoyed it very much. Thank you very much.
Thank you so much, Dr. Asir, a very nice talk. Any questions from the audience? Dr. Oscar, yes.
Thank you, Anna. Beautiful, elegant talk as usual. I just wanted to ask you about Hodgkin lymphoma. What's the, I don't know if you have any information on the CAR-T progress on that.
Okay, so the progress in Hodgkin lymphoma, of course, it has not been as rapid and as spectacular as in large B-cell lymphoma and other B-cell malignancies. By the way, there was a very nice and interesting presentation on chronic lymphocytic leukemia, the Presidential Symposium of EBMT, also showing really very nice results coming from Fred Hutchinson. So there are academic trials in patients with relapsed refractory classical Hodgkin lymphoma. I would say that in US probably the groups that have given more data are the MD Anderson. You may remember that there was an oral presentation at ASH, I think it was 2 years ago, by Saira Ahmed, the Chariot trial really showing very interesting overall response rate and duration of response, but very limited follow-up and very small number of patients in patients with heavily pre-treated classical Hodgkin lymphoma. Also the studies by Carlos Ramos. And in Spain, Javier Briones from Hospital de Sant Pau, they have an academic, let's say in a similar way that Manuel Joan was talking yesterday about the manufacturing process in clinic. They have an academic autologous CD30 CAR T-cell product that has been tested in classical Hodgkin lymphoma and also in CD30 peripheral T-cell lymphoma. Most of the results in relapsed refractory classical Hodgkin lymphoma with a complete remission rate of around 50% and some patients with, let's say, long duration of response, long between inverted commas, because of course the number of patients is still small and the follow-up is still short, but really encouraging results.
Thank you. I have a question about the sequence of therapy. So when you look at autologous transplant, BiTE and CAR T, in DLBCL, how do you sequence them, or what do you think is the right sequence? And is it the same in patients that have early relapse or primary refractory DLBCL versus late relapse or beyond 1 year?
Okay, so I think that nowadays we have changed, let's say, that way that we are looking at patients with relapsed refractory diffuse large B-cell lymphoma. Some years ago we were saying those patients that are transplant eligible and those patients that are transplant ineligible. Nowadays, probably, at least from a theoretical point of view, we should say patients that are candidates for CAR T and patients that are not candidates for CAR T at first relapse. Early relapses, so in the first 12 months, and primary refractory patients, in principle, if there is the option of CAR T, these patients should be going to CAR T. I say should, let's say, with a very thin voice, because the reality is that this is the theory, but from a practical point of view, this theory might not be applicable to many patients. But if you look at the NCCN guidelines and also the last version of the EBMT indications manuscript that I have gone through this table very super quickly, you can see that CAR Ts are the standard of care in these specific groups of patients. So these patients, in principle, the standard of care would be CAR T. The position of autologous stem cell transplantation in this group of patients nowadays is completely unknown, and probably these patients are not going to go into an autologous stem cell transplantation. And of course, for those patients that relapse CAR T, that in fact are going to be more than 50% of them if we follow ZUMA-7 and the Transform trial, this is also an open question, and we might have different options. I think that an excellent option can be bispecific monoclonal antibodies. So both EPCO, you know that EPCO it's already in the approval process. Glofitamab probably is going also to go into the approval process by FDA and hopefully by the EMA. And they have a specific cohorts in the pivotal trials looking at patients failing CAR Ts with really excellent results in terms of complete remission and not different from other subgroups of patients that have been included in the pivotal trials. Auto-transplant, I would say that, it's still, and it's the valid option for patients with late relapses. We don't have, at least for the time being, any evidence that CAR Ts and the prospective clinical trials were not looking at these patients. So for those patients with late relapse, if they achieve a complete remission, partial remission with salvage chemotherapy. And I think that this concept of salvage chemotherapy is going to be implemented in the near future with the introduction of new drugs into the salvage protocol. So these patients should be consolidated with an autologous stem cell transplant. The results of auto-transplant are better in this population of patients, but if they relapse, in principle, I think that the standard of care would be to use CAR T cells as a third-line treatment strategy, and eventually, if they relapse after CAR T, I would say that bispecifics are an option. When bispecifics are approved in third-line therapy, I don't know exactly what's going to happen between bispecifics and CAR T. I think that some of the decisions are going to be driven partially because of by the access to CAR T and eventually the prices and all these type of things. And of course, I have not mentioned anything about other drugs that we have in this setting: polatuzumab, tafasitamab, loncastuximab, and others that might also play a role. Probably, I would say that maybe more in the elderly population of patients and in patients with less aggressive disease.
Thank you. Any follow-up question when you get your patient exposed to bite following CAR T? Any special concern about infectious prophylaxis and
Yeah.
what do you do?
So I think that Claire Roddy has been discussing very well CRS and neurological toxicity and how we have to manage that, and the possibility to use prophylaxis corticosteroids, which was one thing that we were discussing also yesterday. One thing that is sometimes forgotten when we talk about CAR T is that infections are the most important cause of non-relapse mortality in these patients, and that we have to take into consideration these late cytopenias. You may remember the hematotox score developed by Marion Subclave and Kai Rajewski, and probably you will see, hopefully pretty soon, a kind of consensus document that we have put within the harmonization committee of the BMT together with EHA regarding how to manage that. With that, I want to say that these patients are really quite immunosuppressed, and at some point they might be cytopenic, which would be a problem for next therapies. And we know that bispecifics are really very immunosuppressive, and we have quite a lot of experience with the different biospecifics, both in the setting of large B-cell lymphoma and also in the setting of multiple myeloma. And these patients develop really very strange infections that nobody would have thought that they were going to develop. And we are following them. Well, they are usually receiving IVIG periodically, and they are receiving antifungal, antiviral prophylaxis. They are being followed for CMV. So this is one thing that will have to be taken into consideration when we have more experience in combining these strategies.
Thank you so much. Any questions from the group? Okay. Thank you so much.
Thank you.
Thank
you.
Thank you for the audience. It was a great session and a great conference. Thank you to Dr. Askar and the SS BMT organizing committee for great participation and great conference. It was great to see everyone today, and look forward for more conferences down the road. Thank you.